Good afternoon and welcome to this meeting of the Health Overview and Scrutiny Committee. I'd like to inform those present that this meeting is being webcast live and will be capable of repeated viewing. Are any members in attendance as substitutes today? I don't see any indications. I have two apologies, Councillor Hogan and Councillor Begoff. Do any members wish to declare an interest in relation to any matters included on the agenda? Councillor De Oliveira.
Thank you, Chair. I think it's all right, public knowledge. My partner works for the ICS, so I'd like to declare interest in item 8.
Thank you for that. The press and public won't be excluded from this meeting as there are no confidential issues. And I'll now ask the committee to agree the minutes of the HOSC meeting that took place on the 22nd of April 2026. Do members agree the minutes of such meeting? Thank you. Moving on to my chair's communications for today. We're looking at 3 issues today. First, I've asked the Hospital Trust to come and present on the plans to reconfigure the acute floor at the Royal Sussex County Hospital. This is a major capital project that has already seen the creation of new surgical and medical assessment units. We are now entering the phase where the hospital's emergency department is being revamped. We all know that improvements to A&E are urgently needed, and I'm sure we all welcome this reconfiguration. Members will be keen to know what improvements are being made and how this will improve patient experience and the conditions that emergency department staff have to deal with every day. However, rebuilding an emergency department while still running services from the same building is a challenging prospect, and I wanted to give members the opportunity to seek assurances that everything possible is being done to minimise the impact on patients of what will be a long and complex build. While this is the Hospital Trust project, health and care system partners have an important role to play in working together to reduce unnecessary admissions and discharge delays during the build. And members may have questions for NHS commissioners and for adult social care, as well as for University Hospital Sussex. Second, we have an item on cancer diagnosis and treatment. This is an update requested by committee members following a presentation at last November's committee. This item will also be led by University Hospital Sussex. And finally, we have a regular update from NHS Surrey and Sussex Integrated Care Board on changes to the local NHS commissioning landscape. Moving on to public involvement. We have 2 public questions, one from Jo, who uses South Downs Wellbeing Services, and Jo has asked that her question is read out on her behalf, and I'll ask Councillor Evans to do so. Thank you.
Thank you, Chair. The question is, how does South Downs redesign of services demonstrate empowering mental health service user voices when their feedback and complaint portal is designed too small to hold complaints and AI is used to change the meaning of complaints into inaccurate versions of those complaints?
Thank you, Councillor Evans. This question was forwarded to South Down, and I received the following response from them. South Down's complaints process uses a Microsoft customer voice form, which includes a 4,000 character field for describing a complaint. This is normally sufficient for people to explain their concerns. Where additional information is required, it can be submitted by email and is returned in full as part of the complaint record. In some cases, people choose to submit their complaint by email rather than using the form. Where this happens, the service manager enters the complaint into the Microsoft Customer Voice form on the complainant's behalf. If the original email exceeds the 4,000 character limit of the relevant form field, the full email is returned within the complaint record and considered as part of the investigation. In all cases, complaints are explored using all the information we receive. Information recorded within the complaints system is used to support acknowledgement and response correspondence. Where the length of a complaint exceeds the capacity of a relevant field within the system, a summary is used instead, while the full complaint remains available to inform the investigation. This approach is explained to the complainant and is not intended to alter the meaning of the complaint, only to summarise its content. Support and software may be used to produce this summary, and if the complainant feels it is inaccurate, the summary can be updated. And I'll ensure Joe gets a copy of that response. We now have a public question from Mr. Gary Valliere. Mr. Valliere, would you like to come forward and ask your question?
Okay, the independent NHS investigation into wellbeing has now identified actual and potential harm arising from prescribed children and young people. For many months, HOSC declined to pursue questions about local safeguarding arrangements on the basis that an investigation was underway. Now that the report has been published, what specific scrutiny activity will HOSC undertake to examine the wider system issues identified, including relationships between schools, youth services, primary care and specialist gender services? Thank you.
Thank you for your question, Gary. I note the publication of the NHS England review. The review has identified serious issues regarding the clinical approach to care by some GPs at the wellbeing practice, and I welcome the actions taken by NHS England and NHS Surrey and Sussex as set out in the report. Following today's meeting, I will discuss with committee members whether this is an issue they wish to scrutinise in depth. I will consider whether it is appropriate to scrutinise NHS Surrey and Sussex Integrated Care Board's role in commissioning and overseeing local primary care services. This may include inviting the ICB to attend a future meeting. Thank you for answering your question today, Gary. Also today, we have a member letter from Councillor Mitchie Alexander. Councillor Alexander, would you like to come forward and read out your letter?
Good afternoon, everyone. I've been having various conversations recently, as have some of my councillor colleagues, with advocate groups for people with learning disabilities and or autism, and also direct conversations with people with learning disabilities and or autism themselves. They tell me that they find the waiting area in A&E very, very difficult due to their autism. And in fact, one man told me he avoided going to A&E completely because he couldn't face the waiting room. And in the end, his medical condition got suddenly worse due to the fact that his issue couldn't be dealt with when it first arose. Can the chair and committee members ask Universities Hospitals Sussex to please include within the designs of the new A&E at least one quiet autism-friendly room, where someone with certain needs, such as a learning disability or autism, can wait to be assessed. The impact of being very unwell or in a lot of pain is extremely heightened for a person with learning disabilities and or autism, and this could be better managed by having a quiet space available to them while they wait for their assessment. The redesign of the A&E department is the perfect opportunity to consider persons in our city with complex needs and how the area can provide provision in the future for those with more complex needs, so that their wait for assessment can be more manageable for them and their carers, and indeed for the other people waiting in the communal area for their medical assessments. I'm talking here regarding people with learning disabilities or autism, but a separate space or spaces is also extremely necessary for other groups of people too, such as those with dementia. So please can the Chair and the committee members ask that consideration for people with differing complex needs be included in the designs for the new A&E waiting area. Thank you.
Thank you, Councillor Alexander, for presenting that question. You raise a really important issue, and it's something I will ask about when we hear from the Hospital Trust on their plans to improve the Royal Sussex acute floor, and I'm sure members of this committee may have similar questions. Thank you. I'm now going to move on to the first substantive item on the agenda, which is the Royal Sussex County Hospital acute floor reconfiguration. This paper provides an update on the reconfiguration of the emergency floor of the Royal Sussex. We are joined today by Nigel Key, University Sussex Chief Delivery Officer, and also by Craig Marsh, Head of Nursing on the acute floor, and Nikki Mead, the Transformation Programme Manager. And I'll invite you to come up to present to us. Thank you.
Thank you, Chair. Can I also introduce Steve Marlin, who's the Hospital Director for the Brighton Hospital campus, as well. He's joined us today. Can I first of all just start off by saying how pleased we are to be here today, because this is we think, a really important development for the Brighton Hospital campus site, albeit it's an extremely complicated and complex one, but one that we're really keen to make sure that we get right for the future. I'm aware that councillors have got some slides that we've presented before. I don't intend to laboriously go through those slides because I would like to be able to make sure that we spend as much time as possible with Q&As. But there are some points that I think would be really helpful to draw out, and if we can, Chair, it would be helpful just to pick up the question that we recently heard as well. Urgent emergency care is a bit of a broad term. I've included in there one definition of urgent emergency care, but it is very much seen as part of a wide system of different services that are able to respond to patients who have urgent need for that level of service. It is an umbrella term. And within that, we're really keen to make sure that the acute floor on the county site is where services do meet alongside diagnostic support services and other rapid assessment areas to ensure that patients get to the right place at the right time. Our acute floor reconfiguration program includes what most people refer to as A&E, which is what we call the emergency department, or ED, as well as a variety of other services that support that. I thought it was really important, and I just absolutely love these photos. I thought it was important just to give a little bit of context and a little bit of history around the current facilities that we do have. The current A&E opened on the ground floor back in 1970, and an awful lot has changed in terms of the way in which healthcare services are delivered today. So it's quite clear that what was built and designed and opened in 1970 is not fit for purpose for 2026 and beyond. It had 20,000 patients that was intended, but we now see over 100,000 patients every year just through that one ED alone. In 2014, the Care Quality Commission rated our services inadequate and said that the 1970s footprint was no longer fit for purpose, but options to change were limited as it was too late to change what was known as the 3Ts redevelopment plans. It didn't include UE services at the time. So some key moments in terms of our history on the next slide shows you some of the journey from 2009 up until now. I did want to just point out that, and I know some of you would have attended the official opening of the new AMU, Acute Medical Unit, in November last year.
I think it was
December.
We opened the unit in December, and
December.
I think officially we opened it in February.
There we go, thank you. And you can see that actually that's a new unit that is very well used at the moment, and we've received some very positive patient feedback. Prior to that, though, we also opened a surgical assessment unit just above the AMU, and that both those units, both the SAU and the AMU, are part of our urgent emergency care system. And they are designed to ensure that patients get to the right place quicker and don't spend a lot of time in the emergency department. We have got some challenges, though. We know that our patient flow is quite challenged on a day-to-day basis, and that's partly because some of the challenges in safely discharging patients from our wards, and that creates a little bit of a bottleneck through to A&E. And there's a lot of work going on around how we can continue to improve that patient flow through the hospital and back to their home. Some of those discharge delays are complex, and they involve multiple system partners, including mental health services, community services, social care, and of course the private sector as well. So two key challenges that require thinking and solutions as we move through this next phase of the redevelopment of the A&E. One is obviously the demand has considerably outstripped the size of our current footprint, and if anyone has been in the A&E department recently, and I've been in the trust for 18 months, and I still find it a rabbit warren, and I still have to orientate myself within the department because it's complex and it's just not designed for what we need a modern A&E department to do. And then the patient flow, which I mentioned, which is significantly challenged. So we know that bricks and mortar solution is not going to address those. It needs more than just a rebuild. It also needs system improvement and process improvement as part of that. The whole reconfiguration of the A&E department is part of a multi-million-pound modernisation programme that did include the new AMU and the new SAU, but there are still challenges that we have. We know that our facilities don't currently meet new national standards, both in terms of space requirements, but also other requirements and national standards. The configuration of the department doesn't enable optimal patient flow through that department. The environment's really hard to work in, and it's certainly not conducive for any sort of therapeutic environment for patients either. And obviously, our A&E department can never close. We are there 24/7. So it's a complicated multi-year program. And there are some constraints that we are working through to ensure that at the other end of this construction period, we have a fit-for-purpose facility. To quote our chief exec, it's like performing open-heart surgery on the hospital while we continue to provide life-saving urgent emergency care 24 hours a day, 7 days a week for 100,000 plus patients every year. My own analogy is that sometimes feels like you've got to change the tyres on a Formula One car racing around the track because you cannot afford to stop the race. So it is quite a complex project that we have. I think one of the advantages of having such a complex project is also gives us huge opportunities to really take a step back and think about how we're going to deliver the best possible care moving forward. I won't dwell on the next slide because I've mentioned about the first phase that's been completed with the new SAU and the new acute medical unit as well. And we have included some photos there of the inside of that. You'll notice that, and we're increasingly doing this in a number of our facilities across the Trust, using much more interesting ceiling lights, which again we're receiving a lot of very positive comments from patients and families around that aspect of the design. One of the objectives we want to achieve in this next phase is about significantly increasing the what we call the resus area. So that's the space where our most sick and vulnerable patients come into A&E. And our upgraded resuscitation area will be twice the size of it currently is, and also have an additional 2 care spaces in that resus area as well. But we also want to make sure that the modern majors area with clinical cubicles is much better purposefully designed around various needs that different patients have. At this point, I might just get Nikki to talk a little bit more about some of the thinking that we've put in behind some of the designs around how we're going to provide those care spaces that are much more fit for purpose for people with a variety of different needs.
Yeah, thank you, Nigel. So in terms of the general design principles, one of the things we're trying to achieve with the new department is to bring it up to modern standards, and this includes reference to any national guidance and best practice on design of the space to make it comfortable and appropriate for all of our patients, including our patients with neurodiversity and patients with dementia and delirium. So we've given quite a lot of thought during the design process as to how we can factor those things in and improve that environment for patients. So in terms of the spaces themselves, there will be an increase in quieter and low sensory spaces. There's much more individual patient cubicles provided in the new resus, the new majors area, and the new patient assessment and triage areas. That will increase the individual patient cubicles by 76% on our current availability of individual patient spaces. And within that, there'll be benefits for acoustic and noise that will be reduced because there will be walls between the individual patient spaces. Lighting will be adjustable so that we can create calmer, more sensory environments for those patients. In terms of the waiting area, which we had a question on earlier in this meeting, I think that's been recognised as one of the key areas that needs improvement through this programme. I think the Trust would fully acknowledge the current waiting area is very cramped. It doesn't give patients a lot of privacy and dignity, and we hear that coming very strongly through our friends and family test comments. The capacity of our waiting area is going to increase significantly, and the footprint as well. What we're looking to do within the design is create smaller sections of waiting chairs rather than having them all in one large area. So that will give patients an added sense of space. Patients, through work that's going on process improvements within the department already, will have an earlier clinical triage, and that will help us identify where there are patients that would benefit from being taken out of that busy waiting space for their particular individual needs. We're also going to use colour throughout the department to help patients both create a sense of calm, but also provide a visual navigation throughout the department. We know it's confusing in our current area. Many of our clinical kind of areas within the current department look the same. And for patients and their companions coming with them, it's a stressful time. You don't come to the emergency department unless there is something the matter. So using zoning to help patients orientate themselves and feel a sense of progressing through the department is another design feature that we've looked at. And finally, we've taken a lot of care over choosing the right materials and finishes in the department. We've had quite a lot of input from our health and safety team, from our specialist nurses for dementia and delirium, to make sure that the flooring and the walls are kind of finished in a way that isn't reflective, doesn't cause glare, and provides overstimulation for patients. So there have been a number of ways that we've incorporated those needs into the design.
Thanks, Nikki. I've included in the slide deck some schematics of the department. I always find these two-dimensional quite difficult to have a look at. Unfortunately, we haven't quite got a 3D version yet, but we will have at some point in the near future, so I'm more than happy to share those when we get to that point. The final phase of this whole redevelopment is about extending and expanding our urgent treatment centre and the area.
So within the final design, we will get additional resus spaces. So that capacity will be increased. The patient assessment and triage spaces will be increased, which again improves the capacity to take ambulance handovers. And there will be an increase in shared spaces throughout the department, and this is very much in line with national models moving towards emergency-style, same-day emergency care areas, and also the waiting space. Craig, you want to add anything?
Yeah, no, I was just, hi, I'm just, for context, I'm Craig, I'm the head of nursing for, apologies. There we go, sorry. Afternoon, everyone. My name's Craig. I'm the head of nursing for the current emergency floor in Brighton, and I've actually been there in that role for 5 years. So I've been involved in this from the very beginning and seen through the first phase, the second phase, and as we're moving into the redevelopment of the emergency department. And as both Nigel and Nikki have touched on, there is so much we've taken into account from feedback we've received, from the experiences we have ourselves as staff and those that are working in the environment. And not only one thing I want to pick up on is we've just talked about all those different areas. One other thing we were listening to our patients that are coming through, and it's about that journey for patients as well. So we're thinking about how we're signposting for patients, how we're making it very clear what that patient's expected journey is going to be. So, for example, we talk about the waiting room areas. One of the things we're now looking at is actually, just because you've come in and you've been seen doesn't mean that's the waiting room you're going to stay in the whole time. It's actually, this is the waiting room for this part, and then we'll move you on through a journey. So the patients are, recognising that waiting in one place for a long time, you can feel like you're waiting, and the next thing's never going to happen. So it's about helping patients understand what the expectations are going to be, and through that will be through signposting, also through visualisation in terms of, electronic boards and things to keep people updated. And then I suppose probably that next bit to touch is probably through. Do you want to go through the phasing next? I mean, is that the next?
So I was just going to lead Craig and just say we've got a couple of slides around what we're aiming to do in terms of the benefits for patients, but also the benefits for staff, because I think it's important for us to keep all of us reminded about why are we doing this. So I wonder, Craig, if you just like to say a few points around that.
Absolutely. I think so. From a staff perspective, I think both Chair and Nigel have opened it well in terms of, and many of you have probably experienced the emergency department or the emergency floor in Brighton, and the experience of the patients is obviously one thing we have to strongly hold into account, but the other thing is the staff, and the staff that we have there, and the experiences that we hear from the staff and that I see every day. So what we've looked at is taking those things on board. They've been involved in the process all along and helped designing it. So different phases of the design have had different involvement from engagement from the teams. And I relate first. I'll go back to the AMU that's now opened and the engagement we had with the staff there. So the previous AMU had a little bit of daylight coming through into the area, and was very cramped. So the biggest concern from the staff was about the fact that where the new AMU was going to be moving to was going to be basically under the car park or underground. Now, the feedback from the staff ever since, listening to what they've said in terms of now the open spaces, the lighting, the way the lighting's been designed, the ceiling panels, has made a massive difference to those staff in terms of that. Yes, of course, you're underground, but actually for the staff working in the area, the fear they had is significantly improved. The space they've got to work in, the fact that there are, for example, taking into account things that you would maybe have lining a corridor, pieces of equipment that maybe are required, but there's just nowhere for them to be before. They've been taken into account, and now there's corners or pockets or places for those things to go, which makes it significantly better. And then we've taken that same journey for our emergency department staff and recognising that our ED team that are going to be going through some of the same concerns, recognising currently working very cramped. What we've done is we've started taking those staff. They work closely with the AMU anyway, but taking them through and taking them into the space and going, these are what the cubicles are very similar to being, with the walled cubicles, a curtain across the front, that additional space. These are the sort of size of the corridors, the lightings we're going to have, the fact that we can dim the lighting in certain areas as well. And for all the staff, that's essential. The other thing we're obviously taking into account as staff is staff facilities and recognising the things that are required for the staff, staff facilities, staff rooms, staff toilet, changing facilities, those sorts of things. And all of that's being taken into account. Now, that hasn't come with its challenges. We are constricted with the space we physically have, but we have done a fantastic job in terms of balancing all the demands and all the requirements for both the patients and the requirements of the emergency department, but also the requirements of the staff. And we're really confident at the moment from the experience we've had from the elements we've already delivered, but the plans we currently have and the feedback we've had from the staff, albeit currently 2D designs, but also linking that in with the actual physical experience of the AMU. We're really confident this is going to deliver what we need it to deliver for both our patients, but also
And just to add to that, obviously, thank you. Just to add some of the other work that is not always immediately obvious to staff is some of the work that goes on behind the scenes. So quite a lot of digital upgrading has been going on as well as part of this next phase, as well as obviously making sure that things like the layout, ventilation, those sorts of things, that sort of engineering that goes on in the background is also new and upgraded. The benefits for patients obviously are around faster, better clinical decision making, much better privacy and dignity, which is what we're really aiming to do. Continue to make sure that we provide that specialist support for a whole variety of different groups of patients. Better infection control as well, and that's an increasingly important factor. So a better ability to isolate patients if we're concerned about any infectious aspect, and obviously better trauma care. We recently opened the helipad. Still getting quite a lot of keenness and comments from the public who still enjoy watching the helicopters land, but that's an important part of our trauma care, and it is a trauma centre on the Brighton Hospital site, so having a redeveloped A&E department also helps support that trauma care pathway. Do you want to talk a little bit of time frame?
Yeah, so in terms of time frame, there are 3 coming phases of construction still to go. So we've got a package of enabling works that are happening over the next 12 months. These will be ensuring that we have the right spaces available and the critical infrastructure we need ahead of the next 2 major phases of construction. So as part of the enabling works, we're doing things like providing the staff rest facilities and other upgrades to what will be the major south area of the department. Looking ahead then to the next 2 major phases of construction, phase 2 will deliver most of our new resus and our Majors North area. That will last approximately 18 months of construction time, so a significant period. And we've been working very closely together to make sure there's a really feasible plan for the department to keep running throughout that time. It does mean that our existing majors department will entirely decant to other areas within the same level. We will need to change patient pathways to accommodate that. And there are a number of risks associated with it that we're trying to work through, but that phase will last approximately 18 months. Then the phase 3 design will last again another 18 months approximately, and then that will deliver the new walk-in entrance. So for the majority of our patients arriving at the emergency department, the bit that they will see, and the new waiting area, and as part of that we'll get 4 new consultation rooms added to the clinical capacity in that area, which takes us to approximately 2030 in terms of delivering the final design for the department.
Thank you. So in summary, really, obviously it is a complex project. I did want to reassure that we are not losing capacity through this, but it does mean a lot of shuffling around during this next couple of phases around this particular program of works. We're really conscious that it's going to be disruptive for staff, patients, and their families, and obviously we're keen to make sure that we continue to engage with relevant groups to see what else we can do to help mitigate some of that disruption. Happy to take any questions.
Thank you very much all for your presentation, and I will ask members if they have any questions. I'll check them in the order I can see them. Just keep your hands up, please. I think that's everybody. The first hand I did see was Councillor De Oliveira, so over to you.
Thank you. Thank you very much, Chair. Thank you very much to our colleagues presenting. First, I'm going to make a point, then I'm going to ask a question, Chair, if it's okay. I suggest as a member that HOSC may not treat this acute floor configuration as a standalone state project because the report itself shows the real impact and the real pressure systemic. And a build for around 2,000 patients now seeing more than 100,000, so that's 5-fold. With patients' flow blocked by delayed discharge and wider social care failures, any support for the program should go hand in hand with published safeguarding during the construction, proper engagement and co-production with patients, staff and interdisciplinary teams, and a funded plan for social care, mental health, with mental health partners also. So the new building does not just become a bit shinier for the same crisis. So my question is, how much of this reconfiguration is genuinely new capacity, and how much is simply an attempt to make an overstretched system look a bit less unsafe without addressing the wider crisis of social care, mental health beds, and community NHS services?
Councillor, thank you for your question. I think one of the things I really want to get across is that it's not just about a new shiny building. That is important because the environment in which our staff and patients are in at the moment is not fit for purpose. So we do need to improve the environment, but it can't be just about a new building. It absolutely has to be around how we continue to improve the service offer for patients as well, and making sure that we do get patients to the right place much quicker. There are some patients who actually don't need to go to ED. They do need help, support and care, but ED is not always the most appropriate place for them. We need to make sure that we're there to help navigate and get those patients to the right place quickly. And that's part of the thinking behind same-day emergency care units. SAU is the surgical assessment unit, so full of acronyms, is one example of that. So if you're presenting with a surgical problem, it may be entirely appropriate that actually we can get you to the SAU to be sorted out by the surgical team and not to go to A&E. All of those changes also need to happen as in addition to the new environment. But it's also important that we continue to work with our local system partners. So there's a lot of work we're doing with SPFT around mental health demand and how they respond and work with us around responding to the needs of that particular group of patients. That needs to continue. And we obviously need to continue to work with our community services colleagues as well. Have you got anything you want to add?
I think just to echo that, we're very aware that a new building isn't going to solve the systemic issues that are influencing patient flow and overcrowding in the department. So there is some genuine new capacity in this, but we know we have patients in non-clinical capacity currently that this alone will not solve. I think there is, as Nigel's mentioned, some work with mental health colleagues that's already in train, but that is one of our key risks going into phase 2, that there are a lot of mental health patients in the department currently, many of whom don't have a medical reason to be there, which requires a system-wide response to being able to move those patients on. And similarly with backdoor flow, that is a system-wide issue as well, that we need to work with partners to deliver, and will not be a deliverable through this project in isolation. So you're absolutely right, it's a system-wide issue, but it feeds into, I think, some other plans wider than just this programme that are in development with system partners.
And if I may, just to pick up on your point you asked about the additional capacity, I think what's really important to recognise is what we've looked at is what capacity is required with what we have. So, for example, we recognise now our resuscitation areas we talked about isn't large enough, so actually there is an increase in that capacity. We recognise there is a number of patients that actually could be cared for in the emergency department in suitable chaired areas, and again there's an increase in that type of capacity. So what we've also looked at is with the constraints we have, the physical location, as well as all of the other work that needs to go on systemically as well as internally in the organisation, is that actually the space we've had, how to best utilise the space we have, which is a shifting around of the capacity that we do have. So yes, there is an overall increase in capacity in the emergency department. Just not necessarily lots more cubicles, because that isn't always the solution. It's done differently based on the sort of when you look at we've sort of modelled on patients coming through the door, and we can see actually these patients that are on trolleys actually could be on chairs. We just don't have the right chairs or the right area at the moment. We capture that in the rebuild. We can better use our space. And I'm also massively involved in work that we're doing currently to do some of the work into, Nigel touched on medical same-day emergency care units. One of the other areas I oversee is our medical same-day emergency care unit. So when we opened the new AMU, a medical same-day emergency care unit, what we actually did was opened it 24/7, which allows us now to, there are some patients recognising people's lives are changing now. We have people who are attending a medical requirement, but maybe they're attending later in the day, whereas historically they would have attended at 9 o'clock in the morning, but now they're coming at 5 o'clock in the afternoon. We didn't have that facility. We now have that facility. So our next challenge is to make sure that we're maximising those pathways and those processes. So some of those patients that might be sat in the emergency department now actually could be somewhere else. So they're the other things we are working on actively as we speak now, as well as aligning with all the other work that's going on with the rebuild.
Mary from the Old People's Council.
Thank you, Chair. Mary Davies, Chair of the Older People's Council. Older people in the city, who are largely represented as a cohort of patients using these services, welcome the improvements. I was invited to the opening of Phase 1 and can confirm that the new facilities are a spacious and well-designed improvement. Mention was made at the opening meeting about the challenges being anticipated as Phases 2 and 3 progress. It's disappointing, therefore, not to have an equality impact assessment with proposed mitigations before this committee today, which can be updated and amended as the work progresses. Can I request that these are provided to this committee at the earliest opportunity? Thank you.
Thank you for that. The equality impact assessment is something that is being developed alongside the business case that will go through our internal processes for the capital case. So its absence today is not because it's not seen as important or something that we are working towards, but we're very happy to share a copy of that and would anticipate it over the next, it's in development ahead of the autumn, so if that timescale is acceptable to you, then we can share that. Thank you.
Councillor Parrott.
What springs to mind is terrifying, and I admire all of you for taking on such a huge project. I can't even begin to imagine the amount of work and energy that's gone into it. So again, I'd like to reiterate thank you for all of the work, and thank you for coming to present today. I'd just like to take you to the bottom of your presentation, actually, because I do have a comment to make on the quote that you've used at the end of your presentation, and I'm just going to read it just for clarity. To fix the front door of the NHS, we must first fix the back door. We cannot improve emergency care in isolation. It requires a fundamental shift from hospital to community and a partnership between health and social care that is seamless for the patient. Whilst it's a laudable comment, and I recognise that it's come out of the NHS 10-year health plan, which was written by people I probably know, what really concerns me is that actually the patient is missing from that in terms of the dialogue and the co-production. So we're still doing unto the patient as opposed to doing with the patient, who is a tripart of that relationship. There is no NHS, there is no community without the patient. So I really just wanted to make that comment and just, hold that up as a kind of, something to really, really think about. I have concerns about co-production and whether we are actually engaging properly and adequately with the people that actually are the most vulnerable. And so, I'd really invite some comment around that and some thought around that. And if there's anything as Lead for Disability in the city that I can do to help and assist with that, please feel free to get in touch. I guess my question really is about, I welcome Councillor Alexander's question about quiet spaces, and I applaud that, and I think that quiet spaces are absolutely essential and necessary. So again, she asked specifically that we could raise that, so I'm raising that. However, I don't disagree with her, but I think at the end of the day, quiet spaces are at the end of a process. They're a place that we're putting people to wait. There is something about the process from the front door as people come in, which means that they, with all their individual unique needs, whether that's with their patient passports, that they are met in a way that meets their needs. And I'm particularly conscious of that, given we are now talking about an end game of 2030, and last time I checked, we were in the middle of 2026, which, is quite a long time for people with learning disabilities, with autism, with any other form of neurodiversity, with dementia, just no disrespect being aging, we all are, every one of us. I'm an old person myself. So, anyone that is confused or distressed and heightened during that period, the process of how we're going to get them through between the middle of 2026 and 2030, I think is, critical, and I'd like to hear a little more about that. I saw the end game. What I'm not seeing, I think, is the pathway in the next 3.5 years and how we get through. And also, I wanted to be very clear that in 2030, we will have a service that is fit right from the moment somebody puts their foot through the front door, all the way through seamlessly, in terms of triaging that patient, their communication, their needs. How are we going to do that? We've got an increasingly diverse, ageing population here in Brighton and Hove particularly, I'm sure in the rest of the country as well. We've got issues facing us in the UK. These issues, are we going to be fit for purpose? I don't want us to design something that's fit for 2026 and actually isn't fit for 2036. As much as I'd love to be having this conversation with you then, again on repeat, I'd really rather not in 10 years' time be sitting here going, we've now got to redesign A&E because.
Thank you, Councillor. As someone who's also not getting any younger, I completely empathise. So I can only agree with your comments, and I think it's a good challenge in terms of how we continue to ask ourselves: have we really making sure we've got the patient voice through every aspect of this? So, always very open to other ideas, suggestions, and challenge around how we can do that and do it better. I don't think we can over communicate or over consult, or over engage. So I think it's important that we do keep hearing that challenge. I'll pass over to Craig, who I'm sure has got a few comments. But the last thing I want to do is also to go through this next sort of 3.5 years and think, oops, it's now no longer for 2030. So we're absolutely got an eye on the future in terms of what does urgent emergency care need to look like in 2030s, 2040s, and as much of a forward look as we possibly can. The national standard is for people to be seen, treated, sorted within 4 hours, which I'm of arrival. We are got some way to go in terms of meeting that national standard. And although it's not about bricks and mortar and a nice, shiny environment, that will undoubtedly help because it will actually enable us to have a much better systems and process to help in that. I can say as someone who has sat in an A&E waiting room, 4 hours can still seem like an terribly long period of time. So the quicker and shorter that we can do that, and more slicker we can do that for patients from the moment they hit the front door, the better. But Craig.
Yeah, thank you. There's quite a lot I can actually sort of comment on that, actually. So firstly, I think in terms of the patient voice, in an emergency department, it's quite hard to capture that. We obviously receive feedback from patients to our friends and family. We also receive multiple plaudits, but also complaints. So one thing we're currently working on is I'm working closely with the two matrons I have for the emergency department, and we're going to be linking with our hospital nurse director, Therese, to understand whether we think there's some feasibility in us having a forum for to invite the general public to come in to talk to us about specifically the emergency department. So how I know there was we have councils we have governors, patient governors anyway, but what we're thinking about specifically is for the emergency department, and not just because of the rebuild, but just in general, because there's even things now that we can do to improve our department by listening to the people that use it the most. So that's one thing we're already thinking about. The thing I wanted to touch on was exactly what you're talking about in terms of our other patients, and just to sort of assure you all really, and I want to talk from an older person's perspective as well, and said that I work really, really closely with my colleagues in which currently our frailty division, or will be older persons division, and currently they're working so hard to develop other pathways for their patients to avoid coming to the emergency department in the first place wherever possible. And we're even seeing just in 2 weeks of changes to some of the way they're working with their, and again I'm going to bring back the word same day emergency care unit. So we have a frailty same day emergency care unit now in Brighton, and what we're now starting to do is work with the GPs, we have the hospital hub service. I don't know if you're familiar with that, but there's a out at Falmer there's a hub where there's an ambulance clinician there, you've got a UH Sussex clinician there, and you've got other services and access to those services. And then what we're now having is we're creating pathways so that an ambulance might turn up at somebody's house, a frail patient who will bring them into hospital. Before they do that, they're speaking with the hub, and what we're trying to do from there is redirect them to other places so they'll avoid coming to the emergency department in the first place. And some of that's now happening. We're seeing those patients going to for example, our frailty same day emergency care unit, and these are the pathways which, you know, forget about all of the rebuild. These are parts that we're trying to do anyway, because these are things we recognise now. We recognise we've got 4 years until we get to that end point. And we talked a lot about, as you just said, the back door needs to be fixed as much as the front door does. But what we know is that this rebuild will also bring us is gains in efficiency. And the moment we're inefficient with the way we work because of the environment we're currently working in a much improved environment, we can be more efficient. We will be more efficient getting those patients through the system. And part of that we're trying to, as I sort of touched on then, is we're also working through now. So going back to the emergency department, we're looking at our urgent care model. We're looking at how many patients we can redirect to our urgent and emergency care services elsewhere that isn't just the the ED department, because what that will then mean for some of those patients that do genuinely need to be in the emergency department, the majors cubicles, the resus cubicles, will be that we will have less of the other patients there if we're redirecting the right people in the first place. And that's things that we can do now. And one of the other advantages we now have as an organisation, we're a big organisation as a trust. We're 4 big sites. We've got Princess Royal, we've got Worthing, we've got St Richard's, and we've got Brighton. And it's how we're working in conjunction with one another to use the resources, the facilities that we have to maximise our pathways for all of our patients across the whole of Sussex, not just Brighton and Hove.
So this morning I was at the West ICT meeting, which Joe Martindale chairs, and we were discussing there about how many patients come to hospital that could go and be seen in the community and be seen by the GPs. And I was having discussions with the GPs there because they want to do some interventions that will stop patients coming to ED at all, but they want to see that those interventions have an effect. So we can go, try this, does it make a difference? And try that, does that make a difference? So we're going to be sorting out the data, because we can do admission data by age group and by postcode, and we can see where patients are coming from. So then we can see if those GP practices try something and those ones don't, we can compare the data between the two and see if those interventions are making a difference. Because if you look nationally, you can model very easily patients in certain age groups. 80 to 85 who come to ED once a year, and 85 to 90 twice a year, and 90 plus who come 3 times a year. And you can actually model, so you can model your aging population, and you can see if we don't do anything, what our attendance figures are going to be like in 3, 5, 10, 12, 15 years' time. And it's growth, it's just growth. So all of this work we're doing is absolutely essential to stand still in terms of what comes through our front door in the hospital. But we've got to go and work out what we can do and what works and test it and then scale it. So we're doing that with the ICTs, and part of my role is very much engaging with that community work to try and make that difference for the good of all of our patients.
Jeffrey from Health Watch.
Thank you so much for hosting many of us on these grand openings. I'm glad you featured me in 1 or 2 of the photographs. You are flatterers. Health Watch obviously is possibly out the door once the modernisation bill passes through Parliament. And we had a question from the public about patient voices. We're going to be one less point of reference for patients in the future if the bill goes unamended. And I have high hopes that the next Prime Minister hopefully has high regard for Health Watch. So maybe it'll still be there in Health Watch 2.0, who knows. Health Watch has done many enter-and views, and for those of you who don't know what that is, we have statutory powers where we can arrive unannounced and observe and talk to patients and staff and so on, and with a kind of critical friend. And we've been invited by the hospital on numerous occasions to come and do specific parcels of work to try and stand back and help advise. And I don't know what will be in its place when we go, but hopefully there will be something. I have a question really, which is maybe above your pay grade. It was a great shame when 3T's first raised its head way back that money wasn't found to reconfigure the A&E department at the same time. But lots of hands down sofas found 62 million quid's worth of small change. And I just wonder, with a project which is going to get to the finish line in 3.5 years, whether that money is still going to be enough, or are you going to have to cut corners? And if you want to duck it, say, that's fine, we'll find a Bitcoin investor to come in. A lot of people seem to find those these days. Just let us know. Is it going to be enough money? Oh, sorry.
technology is great, isn't it? Thanks for the question, and I can honestly say that we really have enjoyed and will continue to enjoy for as long as we can the relationship with Healthwatch and and who knows, there might be Healthwatch 2.0. We'll keep our eyes and ears open, and certainly it's provided really valuable insights to the work that you've done and helped shape and will continue to shape the services. I think there is something for us around how we continue to tap into Healthwatch during this next phase as well, particularly at certain points, because I think, again, some of your insights during this next phase, I think, will be really helpful as well. Of course, I could sit here and think it'd be lovely to have another 5, 10, 15 million, whatever, but we're also going to be really cognizant of making sure we're delivering value for money for the taxpayer as well. So there are some things that we will continue to tap into charitable trust funds for some of those nice extras to have, which we think are still valuable and important. So we will use other sources of funding as well. But at this stage, we believe there is sufficient money for this next phase of the project. It is quite complex because there is quite a lot of other work going on that people don't see, like a new digital hub and like some of the engineering works that's going on in the background. And they typically are quite expensive to do, but you don't see that in quite the same way. But it's still important work and has wider benefits for the trust, not just for the A&E department. So at this stage, I would say yes, but we will keep a very weathered eye on it. I don't know if Nikki, you want to add?
I think this is something that the project has been challenged with in the past. I think we're in a really strong position at the moment. There's been an awful lot of work to revisit the cost plan for the scheme, and as you would expect with any cost plan of a project this size, there is some costed contingency and risk within that cost plan currently. I think also the total value of the scheme is not still to spend. We've obviously completed phase 1, so some of that has already been delivered through the acute medical unit, but I think we are in a much stronger space with finance on the scheme, and it does build into that risk register things like risks for inflated construction costs. We've obviously had recent geopolitical events which could have impacted that, but just to give some assurance, things like that are taken into consideration when the scheme's being costed.
Yeah, it is a good point around, the geopolitical environment we're in does and can have quite an impact on supply chain, logistics, inflationary pressures.
Just a quick follow-up. When I had occasion to use A&E about 10 years ago, and it was the old, it felt extremely unsafe. I was there sitting surrounded by people in tracksuit bottoms and cans of special brew tipping out of their pockets and axes in their heads and so on. And I discharged myself after 18 hours because it felt safer to be in my own bed if I was going to die rather than there. But I think what I see from the first phase is it is so much calmer, so much better organised, and as in the phrase of an old political song, things can only get better.
Thank you, Geoffrey, for your reflections. Councillor Evans.
Thank you, Chair. Thank you for the presentation. I've got a mixture of comments and questions, I think, and maybe to start where Geoffrey left off. I do remember how chaotic AMU was years ago. However, I'm not sure that A&E is all that different now. I had, unfortunately, occasion to have to use it last week. And on a random early weekday in the middle of summer, it was absolute bedlam. Absolute bedlam. People everywhere. It was an early weekday. There weren't any mental health patients, there weren't any drunk people, there weren't any fights from the town centre or any of that. There were just lots and lots and lots of people. And I walked through from the spanking new, vast, echoing reception area in the main building and all that hugely wasted space, and just, you know, you're talking about not having space for everything you want to do in ED. Well, there's tons of it in that unused reception area. And walked all the way through from there, past all the people being treated in the corridor in the middle of summer, not the NHS winter crisis. And then into an A&E department. We talked about sitting in A&E for 4 hours. There were no seats. There were lots of patients, including me, standing for hours. It was, yeah, chaotic. I felt really sorry for both the staff and all of us patients, as well as sorry for myself. But so I'm kind of a bit reassured by your comments that we will not be losing clinical capacity while all the work is going on. I'm really glad the work is going to go on, and obviously you have to keep the ED going while it does, and I'm really reassured that you have told us we won't be losing any more capacity in terms of the clinical areas. You'll just be a lot of shuffling around. But I'm a bit concerned about the waiting capacity, because it is already so chaotic and there is just no space, and I'm hoping that you can reassure me that in all that shuffling there will be more waiting capacity as well. I also wanted to ask, I was also a bit concerned about the approximately 2030. I was wondering if someone could address that. I also wanted to offer you a slogan, because there's also been some talk about Sam reading out what's written at the end of your thing, and about how it doesn't really include patients. And then Jeffrey said some useful things about that as well. And I just wanted to offer you a slogan that gets used in my party in the disability membership, which is nothing about us without us, which is always worth bearing in mind with anything like that. And on that, not just about patients, about staff too. Again, it's reassuring to hear how much talking you've done to staff, but I just wondered if you could tell me whether, as well as talking to individuals, whether you've talked to all the various healthcare practitioner unions, because I think that's really important. I think that there have historically been, I'm the last person to want to stir up arguments between different types of staff, but there have historically been huge variance between provision for different types of staff, and largely, from all the stories I've ever heard, between the huge variance between permanent staff in hospitals, not just here, everywhere, all hospitals throughout the NHS, between permanent staff and rotating staff, with rotating staff feeling like Z-class citizens who don't even get a computer terminal they can use or a safe place they can leave their valuables. You know, their valuables get stolen while they're working 12-hour shifts, you know, because they don't even have a locker, let alone a place to sit down. And if they ask about it, they get treated like, well, no, all the provision is for the permanent staff. So you can make your own arrangements. Don't bring any valuables to work for your 12-hour shift. You can't expect someone to sit down. So I was just wondering if you could reassure us a bit about the different types of staff, and that they will all be catered for. Thank you.
Thank you. I'll start off, and I'm sure colleagues will have some other comments to add. We do enjoy a very good relationship with our staff side council, who represent all the various unions. And we don't discriminate between substantively employed staff and those who work additional shifts, whether it's overtime or additional bank shift or whatever. They are seen as very much part of the healthcare team. So this, I would be horrified if I saw any examples of that sort of discrimination. That is not, generally speaking, an NHS ethos, certainly not in our trust anyway. Just to reassure you around the 2030, the only note of caution is that, of course, if we have something happens geopolitically, if we have supply chain issues globally, that can impact on the time frame. That's not our plan. We don't want any of that to happen. So it's just a slight note of caution around there are some things that are a little bit out of our direct control. But we are absolutely aiming to have that completed, all done and dusted by 2030. So if it came across that we were fudging it in any way, it's only because there are some things that are a little bit out of our control. Do you want to add some comments, Craig?
Firstly, I'd just like to, on behalf of the emergency department, your experience last week was awful. I think last week doesn't make any excuse. You may have seen we were in a business continuity across our whole organisation last week. It was a really difficult week. We haven't quite put our finger on it quite yet in terms of why we have got so many people attending. Our attendances at the Royal Sussex County Hospital were significantly increased last week, and so it was noticeable. However, 18 hours was not okay for yourself to be waiting there as much as anybody else. And I think some of the things I've touched on earlier, we don't need to wait for the rebuild to happen for us to start improving our pathways for patients when they come through. Now, I don't know why you came to hospital, it's not the case, but what we need to work on is how we better stream patients from that front door to other places. Now, I'm making assumptions, but people who are able to be in a waiting room for 18 hours, there's probably a chance that somewhere else they could be having their treatment, maybe in the hospital, maybe external hospital, maybe they're not there. Because some patients that are in a waiting room could be in our, as I was talking about earlier, in our surgical same-day emergency care unit, or a medical same-day emergency care unit, or we have a respiratory same-day emergency care unit, and we also have a gynecological same-day emergency. So there are other places around the hospital where we need to improve our pathways to get those patients to the right places. In doing so, what that then does is you may not be that patient that goes there, but what it does is it decompresses that other area to then allow more efficient care and hopefully people being able to sit down. With the waiting room of the new rebuild, there is an increase in seating. There's an increase in the waiting room space. But we don't want that increase in waiting room space to mean that it's okay for us to slack off and allow people to wait longer. That's not the point. The point will still be for us to have that, 4 hour, as we should be. That is the gold standard where we should be delivering. Every patient who comes through the front door should within 4 hours have a plan, have somewhere to go or to be discharged from the hospital, and that is something we aspire to do. And I still absolutely, sat in this chair now and in my role as the head of nursing, aspire for us to one day have the gold standard emergency department in our town, in our city, which we can be proud of, which we can be, publicly going to other hospitals and saying, this is how we got there, this is how we got to that point. And that's what I absolutely stand to deliver in the time that we're doing this. I think in picking up on the patients, not the staff, sorry, for the staff again, in terms of the engagement with the staff. And as Nigel just picked up on, we do speak with our staff side. Well, we did engage with all staff. We don't just have, it's not just like nurses, kind of the representation of the nursing. We've obviously as an emergency department, we work so closely with our imaging colleagues, for example, with our colleagues who come and do from the pathology labs. We work really closely with the acute medicals, the consultants, the doctors, the junior doctors. That, as you say, we say rotation. We do have people that rotate in and out because we have. And so, not only have we've identified staff facilities within the footprint of the emergency department. Now, recognising we don't have lots and lots of space, so we haven't got a lock-up of 500 billion staff. But the new building itself, the Louisa Martindale, it was designed also for staff to support staff. So within the Louisa Martindale, there are vast changing facilities which have got lots of lockers, storage space. So it's been provided, and it will be further provided with the staff facilities. But just to assure you, not only did we engage with the ED staff, we've also engaged with anybody that would be impacted by, so pharmacists that might come in and out, with the portering teams, with our housekeeping teams, because, you know, we are one big team. We're not just doctors and nurses in the emergency department, it's everybody. So we've listened to everybody. And, you know, the way hospitals work, you know, there are people have different staff facilities. So, for example, porters might have a different staff facility anyway, but we've taken everything into account when we've engaged with everybody. And similarly to that we did with, as we said, with the phase 1 of the acute medical unit and the surgical assessment unit. So, Nick, you wanted to come in?
So you mentioned winter pressures. It wasn't winter, it was a heat wave pressure, and we've got a heat wave plan. So heat waves happened year on year. We have a heat wave plan which allows us to work out what we do to look after our patients and what we're doing in certain parts of the hospital which have particularly vulnerable patients that, you know, we need to make sure the temperatures are right. What we had was a humidity heat wave which felt unprecedented in that the heat wave plan was no longer sufficient for what happened. And the levels of humidity were such that there were some parts of our hospital where we could not operate the way we do normally, which then log jams down to ED because we couldn't move the patients up, because we couldn't do the procedures they needed, because we couldn't use the equipment. At the same time, South East Coast Ambulance Service went to the highest level of emergency they've ever had, and they were taking a lot longer to get to patients than they would normally, and they went into their own critical incident. So when they then got to the patients, those patients were much more likely to be conveyed to the hospital, and when they arrived in the hospital, were much more likely to need to stay in the ED, to be rehydrated and potentially be admitted because they deteriorated at home. So we had a perfect storm on the back of a heat wave with high humidity, which felt, in fact, I think we were under more pressure than in the depths of winter. It was fundamentally, it was winter on steroids at about the time that you described that you came in. It doesn't excuse your experience. I've only been hospital director, I think 7 weeks now. I was in Worthing before. And I shudder every time I walk through and see patients in the corridor. I absolutely don't want that, and we've got to do what we can to stop it. And we've got to take the lessons from that heat wave with humidity and go, that might happen again. You know, we could get more. So we are now looking at our plans. It wasn't just this trust. The whole country, there were more NHS trusts in business continuity of critical incidents than, well, I've only been in NHS for 3.5 years, but people tell me that in the last 20 years, it was a national problem with that high heat, high humidity. So what you experienced was not what we want, but there were conditions that were unusual, and they were very much like winter.
Can I just clarify a couple of things? One is, thank you for the reassurance about the staff engagement. One is, I wasn't there for anything like 18 hours. That was Jeffrey who mentioned the 18 hours, not me. So nothing like that. But also, it was last week, I would have thought most of the critical incidents I saw being declared in the health service were the week before, when it was super, super, super hot. Last week was a bit of a respite week, wasn't it? Certainly wasn't that hot the evening I was there.
So a number of trusts continued in terms of the critical incident right until last week as well. Now that was partly because of the situation that Stephen talked about, and it took quite a while for organisations to really get back in full control around some of the demand that was coming through, and patients were, you know, clearly unwell when they were eventually conveyed to us in the ambulance. Our admission conversion rate was much higher, so which is a marker in terms of telling us how unwell people were when they were conveyed to us in the ambulance.
Thank you. That does make sense, actually. There did seem to be an awful lot, quite a high percentage of the people that were there had breathing problems, which is probably directly related to the weather. Thank you.
Nora.
I always forget, sorry. Thank you very much for the presentation. I'm here representing the community voluntary sector. I was wondering whether you also thought about the improved access for walk-in patients from the street. So some people come on the bus, and we know there's a steep hill. So for a lot of people, that's quite, quite difficult. And I believe there's still people who struggled to go through the Martindale building to A&E. Is that also part of the planning to look at how to make that more easier for people? Or I know it's a bit tricky because obviously, especially from the outside, walking up the hill, but if you look at from the inside, or people who've come that first time, don't know the area really well, how is there support for people to navigate getting to A&E? I've got a few questions. And also the waiting area, it's really good to hear that it's going to improve and there's going to be more seating and hopefully much calmer space as well. How about the kind of catering or some facilities? I know you mentioned something about facilities, but one thing that came forward was, especially when it was so hot, to have these water spaces where people can get drinks, and a lot of people are scared to lose their seat, so they won't get up and get water. So will there be more spaces where people can get, it's more accessible to snacks and water if needed? Is that something that's also been thought about? And one thing that I found really interesting was about the wayfinding and having volunteer presence. And will they be there to just kind of signpost people where they need to go to? Or because I can see that some people might say, I've been waiting here for a long time and this has happened. And because I think it's a really good idea to have someone there who can make people a bit calmer and talk to them and show them where to go if necessary. And also about the space where you said, and I'm probably not saying it correctly, but you said something about there's the waiting area and then there's this flow that after a while they'll be directed to another area, but it's still a waiting area. So I don't understand that. So if you're sitting there and then you've just been asked, okay, you need to wait a bit longer, but you need to go and sit over there, or how? Yeah, I'm just trying to envisage how that's going to look like, because I'm not sure whether, personally, if I was sitting there, whether I would find that useful. And that was it. Sorry.
Thanks, Nora, really helpful. I'm going to ask Nick to talk a little bit around a couple of those things. That I have to say, during the heat wave, I actually ended up having a couple of days off sick with heat exhaustion. Climbing up that blinking hill in the morning and I was clearly dehydrated, so it is a good point. I think there is some more work we can do around some of the internal wayfinding, particularly people coming in the main entrance and finding their way to Edith, and Nick can talk about that in a little minute. I recently visited a relatively new hospital in another part of the country, and they had a number of different sub-weight areas. And it was interesting talking to some patients who found that incredibly frustrating, because you thought, finally I'm going to be seen. No, it was another waiting area, and that we don't want to create that scenario, but we do want to make sure that we do create spaces where it is calmer and people are feeling like they are progressing, as Craig said, and being seen. So we don't want to just move people from one waiting area to another waiting area to another waiting area. That's not what it's about. But it is about making sure we do create those waiting areas that are a lot more conducive. But Nick, do you want to comment on the wayfinding?
Yeah, absolutely. So, fully appreciate it's not ideal to have the entrance to an emergency department up the top of the hill. I mean, ideally, it would be far more accessible on the main road, but there's not an option to move the physical location of the department. We're giving quite a lot of thought about how we can help people through the phasing, but also it will remain in that location at the end. Within the Louisa Martindale, we have a really good reception team that greet a lot of the patients that come into that front door, and they often have capacity to escort patients up to the department. So use of volunteers is definitely something that will be lent upon and maximised. I think within the trust there's also been quite a bit of work since Louise and Martindale building opened on wayfinding within the site. We know it's a Warren. Whenever I walk around, there are people that I end up directing to and from different parts of the hospital. There's someone in our comms team that's done a lot of work on that, having previously worked at Gatwick, where there's the use of colours that are helpful in terms of wayfinding to specific areas. So we can kind of certainly have a conversation with them and see if there's additional works planned. But within the department, just picking up your comments on waiting, that area will be, as mentioned, expanded. I think the subweights that Craig was mentioning, the idea is that the patients would only move if they are going to a different stage in their patient journey. So they wouldn't be moving for moving's sake. It would be when that they are they've seen a clinician first of all, been streamed to the appropriate area of the department. Maybe they're then seen and identified as being suitable to sit in a chair in our ambulatory clinical decision unit, and it would be at that point that they would move to a different chaired area. So it's tying it to different stages in their patient pathway, so that the movement between areas, because at the moment, what I'm sure if you've been to the department recently, it's that same waiting area, and you sit there, you go in, you get triage, you come back to the same space unless someone else has sat in the space that you were in previously. You then go and see a clinician in one of the consult rooms, you might come back to the same waiting area. So there's multiple points within your patient journey where you're just returning to the same waiting area, and it can feel like a dreadfully long time. So it's tying in the different subweights and shared areas with progress in the patient journey as well. So not just around shuffling people about the department. Refreshments and catering is something that when we get the new waiting area, there will be provision for water dispensers within that space. And at the moment we don't have vending facilities within the waiting room itself. You actually physically have to walk down the corridor to access that, and there's a little RVS coffee shop as well around the corner. Vending facilities will be within the waiting space in the final design, so patients won't have to leave the area and risk losing their seat, which we hope would also be less of an issue when we've got bigger capacity in that area. So we have given some thought there, but that will be in the final phase rather than during phases, phase 2 and phase 3, when that waiting area will be the same. I think, yeah, wayfinding, as I say, we're doing a bit of thinking around that, and also looking at national best practice. There are documents from the Design Council about reducing violence and aggression in the emergency department, which actually have some very good practice for all patients in terms of making sure that they have better understanding of where they are in their patient journey and what the area they're in, what they're waiting for. So, Craig, do you want to add anything to that?
Not really. I think I probably didn't make myself clear when I was speaking before, so apologies for that. It's absolutely about that sub-waiting. It's about that patient journey. It's not about moving someone for the sake of moving. So if someone arrives and there's a waiting space, they're triaged by a nurse, and then they're directed to a different part where there's a different waiting room. And the key to all of that, though, is by the communication, is us being really clear about what the next step is for them, because we absolutely wouldn't want people being confused and moved around for the sake of moving around. That wouldn't be the purpose. And we do, I think, volunteers are a huge asset to how we work now. I think, like all things, they are huge assets to us, but we can't become dependent on them because they are volunteers and they may not always be there. So we do still have to recognise that we can't have a system or a process that relies on the volunteer to be there. They make a massive difference when they are there, and we will absolutely wish and hope that we do have as many volunteers as we currently do, but we also still need to have wayfinding and processes that are in place that we can still run the emergency department without, without leaning and needing volunteers.
Follow-up question. So if someone comes to the Martindale, every time I'm thinking Joe Martindale, but the building, and they come in, and if they really struggle and they say, I can't walk up that hill, I just can't, is there anyone to help me? Is there that facility available that someone can then take them to A&E, or will they still have to make their own way?
So it's a facility that now, for example, if someone turned up at the reception now and they need to go to the emergency department and they couldn't make it to the emergency department, there would be someone that would do that. Whether that be calling the portering team to do that, or whether that would be a volunteer that would be around, they would be able to do that. It's not a specific facility that we've put in, if that makes sense, but it would be available. Obviously, if someone walked into Louisa Martindale and was extremely out of breath, and everybody was very concerned about them, they may even call an ambulance or put an emergency call to get them taken through. So that is there, and that's already there now and in existence, in the sense that reception area that's there, if somebody walks in there. I guess, and it might be a question that we might need to take away and consider, but overnight, some walking up the hill at night, there is no that reception area at night, so that might be something for us to take away and consider. I don't have a specific answer to that, but now, certainly if someone came in through the Louisa Martindale, as you described, and needed to be taken to ED, they would be able to do that.
And sorry, just there is a wayfinder, a signposted route through the buildings, which can be done using lift access only. You don't have to walk up either the hill or the stairs. So there is a way of, just by using the lifts, for the public to access the ED from the Louisa Martindale.
Councillor Winder.
Thank you. I wanted to say that we seem to have got to a really good place in this discussion, because from moving on from how do people find their way around, we're actually talking about how they get there and how they feel when they get there. So I feel really optimistic about where we could go with all this. But one thing that's come across in the media in recent weeks is about, particularly when talking about maternity services, and how people felt that a lot of staff had forgotten how to be kind. And I just wondered how we might bring that into all this, because people will be going to an emergency department because they're very unwell and they're frightened and so on. But how do we get that talking from staff as well as maybe volunteers as well, about being reassuring and caring, and people feeling very safe when they're there, and not that they're going to be blamed for something, or that they've somehow ended up in the wrong place, outside their control. And it is kind of like about the patient experience, isn't it, and valuing that, not just kind of dealing with it. And so I just wondered how we would also think about GP services contributing more to that, so that people don't feel that they're having this experience at a GP's, they can never get an appointment, they can never ask for help, and so they end up at A&E, for example, because they can't go anywhere else, and how that might be kind of joined up a bit better. So yeah, it's just how does all this work in creating a gentle and safe and kind environment wherever you are, and knowing that somebody will help you to get better.
Thank you, Councillor. It's really interesting that a service can deliver really good clinical care and having really good clinical outcomes, but the patient experience can be not brilliant, and both can be true. So I guess that, our challenge to ourselves is, how do we do both? How do we make sure that we continue to deliver really good clinical care with really good clinical outcomes and the patient experience is just as good. And I think that's a continual challenge that we've got to give ourselves around how we do that. The environment doesn't help, though, and I don't want to use the environment as an excuse, but it definitely doesn't help either staff or patients, and I would add carers into that as well. So we can do some things around the environment, and that's what we want to do with this next phase of our redevelopment. But there is also something about how we continue to make sure that we get that patient voice, that previous councillor's comment, into what we do and how we're doing it. So I think there is some more work we need to do around how do we weave that in. As Craig said, it's not always easy to get ED patients' voice in there. Patients will often engage with specific services, whether it's cancer services or respiratory services or whatever it might be. But for ED, it can be a little bit more challenging around that because it's quite diverse. But I think there is something about how do we do that. So thoughts and ideas or suggestions always welcome. And of course, we've got our friends in Health Watch who can help with some of that as well. Great.
I was just going to say on that note that actually, what we recognise is that patients or anybody that comes to the emergency department is probably at their most vulnerable and are probably going through the worst experience they could be going through for whatever reason that might be, whether they're a relative or whether they're a patient. And I have a team of staff that have had to work in some really difficult environment and situations for a long period of time, and actually it's a real challenge sometimes. Actually, people become staff, and very open and honest, people become empathetically damaged after a period of time because you're working in that sort of environment. But it's us as leadership, it's our responsibility to make sure that we're still empowering the staff and creating that environment for them to care. At the end of the day, the reason we've all moved is not for the money. We haven't gone to the NHS for the money. We've gone to it because we care about what we do and the people we serve or look after, and that therefore is then our responsibility. So it's as much as linking and listening to what the patients are telling us. I'm so proud that we receive 3 times as many as plaudits as we do complaints. And when we get the complaints, we take them really seriously. It might be just someone's had a terrible, maybe a small misunderstanding with a member of staff. We deal with that because it's so important. And it's something we pride ourselves in being compassionate despite the challenges we face. I think Nigel's point is also really valid in the sense that actually it can be difficult. You're working in a very, very difficult environment with people who are feeling really vulnerable, lots of differing groups of patients in a hot pan of a current very congested environment. You may have patients with mental health challenges, with crises, people coming in who are confused, agitated. Then you've got somebody coming in with his fallen over in the street and broken their leg. So you've got a multiple combination of people, and so it's our responsibility. And there's absolutely there's no excuses for us there's reasons why we might be challenged to do so, but there's no excuses in my eyes for why that compassion shouldn't come across and should always be there, because that is the reason we're there in the first place. And I think just picking up on your other point you said about the GPs, I think it's a really good, there's always conversations about how we work with GPs, and I bring back to my frailty colleagues or my older person colleagues, and currently we've got a project at the moment where they are reaching out to local GP services and linking in with them. We're looking at some of the GP services that maybe have the higher number of patients then get redirected to hospital, and working with them to understand, is there something about their dynamic, their cohort of patients that are attending their practice? Is it something to do with some education and some redirection we can provide them with? So there's already work that's happening underway with the GPs. And I don't know if Nikki, is there any other?
I think that is an area that there's opportunity in, and it's an area that I think kind of nationally there's a focus on kind of neighbourhood teams working more closely together, and it's I think that's a kind of a stage of development here, but there are some really good examples where we've got kind of teams going out to make that contact with local GPs, putting clinicians from the hospital in touch with those practices and those professionals out in the community, and that is really showing some impact on reducing attendances and length of stay for patients in those areas. And there's absolutely, I think, opportunity to scale that up through other work that the Trust and the wider system will be working on.
And part of that is our responsibility, even in the emergency department, to be able to identify sometimes patients who maybe have come through and perhaps they could have been seen differently in the community beforehand, and then it's our responsibility to make that escalate to the channel so that Nigel and the other execs from the organisation are interacting with their colleagues in the ICB or wherever that may be, that they can then feed these conversations through. So there's multiple channels, and again, we've come here talking about the rebuild, but these things that are happening and should be happening, whether there's a rebuild happening or not, and we are working on as many different ways at the moment to deal with the challenge we're facing in our hospital and in the emergency department. Even put this to one side, as it were.
Councillor Hill.
Thank you. I've got a couple of questions. So firstly, got sent some useful data by David, one of my residents, that was about average instances of corridor care use in the emergency department for local hospital trusts, and it mentions that the average instances in May of this year, I believe, was 65 for corridor care, and that's based on NHS data. So that's making our trust, therefore, 6th worst out of 125 trusts. And that might be a one-off, but obviously we'll see over the next months. There's also been reporting in the Telegraph about, because obviously, naturally we have this drive to end corridor care, they're reporting that that's led to people being trapped in car parks as patients in the backs of ambulances. So I'm wondering if you could comment on that specific concern that's been raised nationally, and if that's a known issue locally, and also because clearly there are other trusts that will have similar issues to us with old buildings, limited space. Why are we doing quite so badly out of the pack, so to speak, in terms of those figures? Yeah, that's my first question. I've just got one more, but quite separate, so I'll start with that.
Thank you, Councillor. So we definitely recognise that we have far too many patients in corridor spaces than we would like. We'd like zero, actually. But we've got some work to do to get to that point. The NHS England only fairly recently published a national definition around corridor care, and hopefully we will start being able to compare apples with apples a little bit more in terms of that. We're really focusing on making sure that if we've got patients in a corridor, how do we keep the amount of time they're in that corridor to as short a time as possible? So it's not just the numbers of patients, but it's also looking at the length of time that those patients are in the corridor as well. We're doing some work with the National GIFT team, Getting It Right First Time team, who are working with us at the moment, and one aspect, there's a number of different aspects they're working with us on, but all of that will help contribute to reducing the amount of corridor care that we have. We have it on all 4 sites in our trust, but Brighton is particularly challenged around that. I think today we have 15 odd patients in the corridor, so we've got the data, we know what it says. I look at it several times a day personally. So we know it's a challenge, but there is quite a lot of work going on in terms of how we make sure we minimise any time that any patient has to spend on the corridor. Craig.
Yeah, I think just also to pick up another point you raised with the ambulances, one thing we've absolutely pride ourselves through is that we don't hold people on the back of ambulances in Brighton. Every ambulance that arrives comes into the emergency department purely because we need to make a very quick judgment of whether someone actually needs to be in our resuscitation area. It might well be that we sometimes hold a few ambulance crews in the emergency department because we haven't physically been able to make a space for that patient to come in, but we don't hold people on the back of ambulances in Brighton. It's something where other trusts at periods we're holding patients in the back of ambulances for hours and hours on end. We were priding ourselves on, albeit it had an impact because we then had more patients in the corridor, but we had patients in the department rather than being on the back of ambulances, something we did. And I think just bringing up your subject about the care in the corridor, yes, it does happen. And part of my responsibility and the trust responsibility is to stop it from happening. But part of my responsibility as head nursing for the emergency department is, if it is happening, to do everything I can to assure those patients that are in the corridor are getting the best care they can get where they are. And that is what we're absolutely committed to. So there's two elements. That one is to eradicate it and stop it from happening altogether. But the other part is, while it is happening, there is a responsibility to make sure we're doing everything we can to ensure those patients are still getting the same quality level of care that you'd expect.
Thanks. Those are helpful answers, so I appreciate that. So sort of separate questions. So we touched on flow as an issue which can be caused by people being often told to present to A&E when actually they want to be elsewhere in different departments. So I've got sort of a specific concern, which is relating to the early pregnancy units, because currently if you call the early pregnancy unit, you get told, depending on what you'll say, that you have to present to A&E in order to be referred there, and that can lead to potentially hours of waiting, by which time often your pregnancy complications may have progressed significantly. So could it be possible to allow direct referral to departments like the early pregnancy unit? And the early pregnancy unit also seems to lack capacity to take people, particularly like overnight, from A&E, and that leads to people being stuck in A&E in what is a psychologically unsafe environment, especially for somebody experiencing pregnancy complications. And often it feels like A&E staff are either too burnt out or, on a sense, not maybe well trained to support people experiencing pregnancy complications. So I don't claim to have expertise on patient flow, but I know this isn't working well right now. So I just wonder if you could comment on that. Thank you.
I'll make a start. I guess there is the principle around which we talked about before, around having some of those same-day emergency care units. And we talked about gynae, we talked about surgery, a number of others. The early pregnancy service needs to be seen in that context as well. I'm certainly happy to take that away and just have a wee further look, particularly around the out of hours aspect for the early pregnancy unit. I agree that these patients who are presenting need to be able to present in the right place at the right time easily, and we need to see what we can do out of hours. So I'll definitely take that away. But the principle was absolutely the same for every specialty. How do we make sure that we've got those other units that enables those patients to get to the right specialty as quickly as possible? Is there anything else you want to add?
Just pick up that point, I think, we do direct to areas, and it's like I think I mentioned earlier about the hub that we have, where the ambulance service can have direct access to our clinicians, which means they can direct patients directly to our same-day emergency care areas, whether that be the medical area. So I can't speak on behalf of the early pregnancy unit, but I do know that we have access to other areas of which we do directly stream people. Either people can present and we stream them there, or we will hopefully have them to be told through 111 or through the ambulance service to go there directly in the first place.
Councillor Simon.
Thank you, Chair. So some of my questions have sort of been partially addressed, so hopefully they'll be relatively short and then just require a bit of clarification. But I have 5, but I promise it won't be too. They're quite focused. So in terms of, I was really, really pleased to see some sort of focus on natural light and views of nature. My mother was in what I presume is the AMU, I forget now, with no natural light for 5 days. And as somebody who never, ever experienced any mental health difficulties at all, she started to experience psychosis because she was out, well, because there were probably all sorts of drugs that she was being given as well, but for her condition, but which she'd never had before. So that, but also that just that literally not not having any natural light and also having, you know, quite harsh clinical light around her all the time. And that, I think, is, if that's not a part of the reason for having those lights, then I think that's, I'd be interested to know if that is something that you're aware of, that those things happen to people when they're not, when they don't experience those views of light and nature. So is that, it'd be really interesting to know if that idea is being expanded throughout the rest of the modern estate, not just this small unit that's underground, because there are a lot of areas where people don't have views of natural light. I was unfortunate enough to go to Southmead Hospital a few months ago, which is a lovely shiny new building with this beautiful atrium with lots of plants growing inside, and all the windows either face out onto the universe or they face into this atrium that's full of nature. So you know, I know you can't do everything, but just those pictures on the ceiling just seem to be sort of a bit joyful. So that's good to see. But it'd be interesting to know your sort of, you know, what the reasons are for that, whether they align with what I think. You know, everybody's an expert. It's just like the schools, isn't it? Everyone went to school. Everyone's been to hospital. So we're all I feel your pain. You know, we all think we know what we're talking about. But I'm happy for you to be the experts. So that's the first thing about natural light. Wayfinding. I'm very happy as somebody who experiences massive health anxiety and has no sense of direction to come and volunteer to test out any of your wayfinding for you. I really think you need to find people who struggle, because I have never, ever managed to navigate that hospital without turning into a gibbering wreck at some point in a corridor. And I have to say, being rescued by really kind, lovely staff. So, you know, there is some compassion fatigue, but it's not endemic. It's that there are lots of lovely people who are very helpful. But I think it's really important to have those systems tested by your kind of worst case scenario, and I might be that person. So, you know, there's an offer. And it sounds to me, I was going to ask about how much frontline staff and patients have been involved in identifying risks and designing mitigations, but it sounds to me like they have been a lot. And obviously it's those people at the coalface who really can, they've got all the ideas, they've experienced it, and again, patients as well. So it'd be good if you could just clarify that, but it sounds like that's a big yes, so that's really positive. You say something about, in the mitigations, you talk about mental health provision, and you say the risks cannot be resolved through operational actions alone. It requires system-level working. Can you elaborate as to, you know, for me, as a non-sort of expert, what you mean by that? What are the mitigations that can be put in place within the system? And then at the end, you talk about a hospital shift to community care prevention. So we don't just want to kind of open up the back door. We also want to prevent people needing to come through the front door. So could you elaborate or give a bit more detail on how you're reaching deprived communities? How local, I'm particularly interested in how local local services are. For context, I'm a councillor for Woodingdean, and we're often told that there's a local hub on the east of the city, but what that really means is Whitehawk, which is 2 buses away. So I'd like to know, are you truly going out into local community spaces, and how do people know, and how can I know so that I can inform my community what's being done for them? So I think those are all my questions. Thank you.
Okay, I'll make a start, but I'm sure we'll take you up on your offer to be a bit of a tester for the wayfinding. But you're right in terms of it's always good to try and find people who, who identify as, I have a real problem with this, and if we can tap into those people and test something out, then that's actually really, really helpful. So we'll take you up on that offer, and we'll see if we can find a couple of others as well. Just in terms of the mental health, so SPFT have got, that's the Partnership Trust who deliver mental health services, have got quite an extensive improvement plan of their own that they're working on. Their improvement plan includes some of the upstream community-based services for mental health patients. It also includes looking at how they might develop I call them a mental health ED. I think nationally it's probably got a slightly different title, but that's what it is. So they're working on a proposal around that'll be on the county site, which I think will be a really good development and provide a much better alternative for that group of patients. So they've got quite an elaborate, well-structured improvement plan of their own that they're working on around mental health provision. Do you want to comment on some of the other things?
Yeah, absolutely, and I might circle back to that as well. So natural light and nature, certainly the approach which we mentioned earlier that's been really successful in the acute medical unit is the use of skylights with trees on them, and that is absolutely an approach that's going to be taken in the rest of the emergency department. It's not ideal. We know that the department has no or very limited natural light. There is a bit on what will be the major south side of the unit, but it's very limited. So there will be skylights throughout the department, which will generally be placed as in AMU in the kind of circulation areas. So the idea being that it wouldn't be too kind of up and close for individual patients, but something that many patients will be able to benefit from one light. And it's something that we've involved staff in choosing the images for AMU, and that was actually a really successful piece of staff engagement.
And just to build on that, some very useful, quite a lot of research has been done around how you use that, and quite some really helpful Canadian research that's been used worldwide around how you do that. So it's not just something we're making up ourselves.
It isn't. No, I think that it kind of entered the brief because we are looking to create a calm and environment that will reduce kind of people's stress levels. So the idea of bringing nature into it and giving that sense of natural light where we know that there is limited actual windows was very much born of that as well. Wayfinding, I'd love to have you to test it, and probably for each phase as well, because it's going to change multiple times, so that would be great. And the frontline staff and patient involvement, as Craig mentioned earlier, we have spent a lot of time talking with staff across a range of professional groups within the hospital and reaching out to our external partners like the Mental Health Trust as well, who have a liaison team that work directly in the department. So it's something we've taken a lot of time to do. Patient involvement, I think we've used a lot of the friends and family comments and also the Health Watch reports from previous visits. But I think looking forward in the project, it's something that we would like to do more with. And I think that links in with what Craig was saying more generally around patient involvement within the emergency departments. And then in terms of mental health provision, currently there is an area within the department where mental health patients are cared for who have no medical reason to be on the county site and awaiting a mental health bed with our SPFT colleagues. That area is not replicated in the future department because those patients are not patients that really should be within the emergency department, and actually being in that environment is quite detrimental for their recovery. It's not an ideal environment at all. the scale of that problem does require kind of further system level working with our mental health colleagues. We know that there are some improvements we can do more locally, but that's not going to deliver the scale of change that we need for that area to close without there being an impact on the wider departments. There is very close discussions with our mental health colleagues at the minute about how that can progress. But at the moment, there is still a need to further mitigate that risk.
You talked about the community bit as well. So I touched on it earlier when the meeting went through this morning. So the community trust, not the community trust, the integrated neighbourhood teams or community teams, going two different names at the moment, but they're settled on one eventually. That is where that really local work happens. They are getting, and I will be attending both the East Central and West ICTs, representing our trust in that work. They are very much collaborative pieces of work, but they're very much locally led with local sort of demand on it. The GPs are there, social workers are there. There's a lot of people there, and there is money flowing with the shift left into that work. So as they come up with their own local ideas, there should be a way in which those ideas get funded and tested, and then the ones that work then get scaled. So it doesn't quite answer your question, how do I find out about exactly this in my area? But the whole point about those being local is not to go and dictate from on high, you all are going to do this, but to go local and go, what is it you want to do that you think your community needs, that we then try and support. So you are going to see a bit of a patchwork as people try things, learn things, and copy from each other, and then the good things will spread.
Hello, councillors. I am Tanya Brown-Griffith from the ICB, and I thought I'd just add to that because there's a wider piece of work around neighbourhood health that's happening in the community, and I know councillors referenced some of the work around that. I think you referenced a community hub, and that is an exemplar of good practice, but it's not fully rolled out across the city yet. It is a test of change in the Whitehawk area particularly, and I think, as Stephen mentioned, it has all stakeholders involved, from voluntary to NHS trust across primary, community, acute, but also in terms of the local authority, adult social care, housing, drug and alcohol, public health services, prevention, screening. So we're testing and learning, and I actually have in my update later the fact that they were nominated and won a regional excellence prize. So it is a good practice that we're learning from to roll out across the city. I think councillors will also be aware around neighbourhood health. There is the neighbourhood health centres that will be coming on stream over the next, I believe, 5 to 10 years. And we're looking at the East Brighton model to see what other hubs we could have across the city. We haven't got timeframes yet because some of that depends on, as Stephen mentioned, some of the left shift money and how that's cascaded across Surrey and Sussex. In Sussex, quite opportunistically, we have a neighbourhood health alliance, which is made up of NHS providers, but also includes local authority and BCSE sector partners in that, and hospice alliance sector partners involved. And what we hope, and we've started to, is to left shift a certain amount of money to the hospital, to the neighbourhood alliance, to be able to cascade, like good practice, like the hub can be funded if it's the way to do care for that community. It might be a frailty hub that's needed in the west of the city. It's not going to be a one-size-fits-all, but it's based on need, and as Stephen mentioned, based on the delivery plan of that neighbourhood to meet the needs of that population. And really good example of where the acute trust has outreached into the community to provide things like respiratory I believe clinics, as well as respiratory advice and support, as well as other disease management. And so we're looking at that model to roll out further to other areas. But it is obviously a test of change, and it hopefully, once we have that agreed across the city, there'll be a directory of services that can be provided.
Thank you. Councillor De Oliveira.
Thank you. Just because early on the conversation mentioned the modelling, if you remember that. But I was quite interested on the model. I wonder if you could unpack there. Because a model, it's unreliable, it's assumption of the data, the cost of the data, stress testing. So if it underestimates, uncertainty, exclude convenient variables like winter surge, respiratory disease waves, staff vacancies, sickness absence, agency staff limits, so on and so forth, delaying handovers delay, so it can really build there. So it can give wrong answers. So the model could be wrong and produce something that it can be misleading. So sometimes have this assumption there, or you build a hospital that was estimate for 20,000. So someone made a modeling there at some point, I suspect. And the modeling only got wrong by 80,000 per year. So based on that, so what independent stress testing has been done on the current modeling, and what changes will be made if the model proves to be wrong as it proved to be wrong before?
So just trying to understand your question. Is your question around the demand and capacity modelling?
So it's about the modelling, because you said you create a modelling. So there you had a modelling before the estimate 20,000. Now you have a modelling that estimates 100. Which kind of independent stress test are you putting in place to not give another wrong reading?
Okay, I think that's what we would talk about in terms of demand capacity modelling.
Yeah.
So we have very well recognised national tools around demand capacity modelling. So we're not doing anything that is inconsistent with what the national planning assumptions around that. And it builds in things like demographic growth and a whole range of other factors as well in terms of the demand and capacity modelling. That's updated at least every year. So all of our demand and capacity modelling for all of our services gets updated every year to take into account all that, and that's all part of the national annual planning cycle that we have in the NHS. I'm not sure
I can come in. So when this project kicked off a few years ago, there was the modelling that was used to determine how many spaces we needed in which area was based on the attendances that were coming to the emergency department at that point, and then it was built into a 10-year forecast model which included growth, which was at a very generous level that hasn't been realised at quite the same level because we had COVID come in and completely disrupt attendances for a good few years. So it was built on a modelled expected attendances. What I think then we did was looked at the percentage of patients we expected to go to different areas of the department. So the percentage of patients we expected to go to resus, the percentage we expected to go to majors, to then inform how many spaces we needed in those areas, to try and make sure that we were building the right capacity for not for the year we were doing the work, but for the future. So that obviously, since the modelling was done, there's been some changes to clinical models. Like I think what we've been able to do through the development of the design is put in the emphasis more on ambulatory areas, which is in line with national practice. And we've been able to increase capacity in those areas and try and take account of that. But I think the question, any model has its assumptions. There is a risk with any model that it's not going to come through in reality, and certainly knowing the one that this was originally based on, COVID came in and actually meant that the increase in attendances that were expected in the first 5 years didn't come through, although I think we are now seeing that increase coming through in the last 12, 18 months, and probably at a higher level of growth in the last 12, 18 months than would have otherwise been expected. So, yeah, there was a model. There acknowledged there's risks with any modelling, but it's been done very much in line with kind of national practice.
No, I think that is reassuring. I'm a social scientist myself, and that you get a modelling wrong by 80,000 is a oops moment, really. So I hope, for predicting 20,000 to go to 100, it's a bit of raise questions. How can you get the modelling with the assumption you have at the time that wrong?
Can I just clarify? The 20,000 was the number of attendances that the emergency department was actually receiving in 1970 versus the actual figures that are now coming through. Yeah. So it wasn't a modelled figure. Those were kind of actual figures from previously when our current department was built versus the actual figures that we're now seeing, not the ones that we've modelled the future need on. I hope that helps. Thank you.
Jeffrey.
You're very kind letting me back in. We're into extra time now. It will be penalties soon. I just wanted to pick up on Councillor Hill's point about corridor care, and really just seeing corridor care doesn't happen by chance. It usually happens because people are occupying beds and they can't be safely discharged. So what kind of liaison do you have with social services, which is operated from this building? And these are things beyond your control. The other point I wanted to pick up on as well is that the external forces that you're having to deal with that have an impact on A&E will include the police. And they are responsible quite often for bringing people in having mental health crises into A&E. And if you're telling me now, or telling us, that there won't be an A&E space for people in mental health crisis, how do we educate the police not to bring them there? Or not to sling them in a cell as well, which is the other practice.
So yes, you're right in terms of the police are another important partner in our system around there. So it's not that there's going to be no mental health facility. That's exactly what SPFT are working on in terms of creating that mental health ED. Unfortunately, the timeframes at the moment don't quite align with our rebuilding. So that's where some of the further work needs to be done in terms of what are the other things we need to do in that period between us not having 2C, as it's known, in the emergency department and the new mental health ED facility on site. So that bridge, if you like, is something that we are working on, particularly with SPFT. The police are an important part of that because they will convey patients to ED, and so there's a lot of work, again, interagency work going on with them in terms of some of those pathways. We get quite a lot of what's known as Section 136 patients that do get conveyed to both here and Haywards Heath, actually. And so that is some ongoing work with the police, but they are an absolute part of that group of patients.
Yeah, I think just in terms of our mental health trust colleagues, they have a service called Blue Light Line, which is like a triage service that is available for other professionals. So if the police go out and attend a patient who's in mental health crisis, they can ring through to the Blue Light Line direct and take advice. I think one of the other services that SPFT offer is a crisis response team where they can physically dispatch a team to go and assess a patient and hopefully avoid an attendance. But I think they would acknowledge that both of those are an area that they want to develop more.
Just to offer some assurance that the rebuild doesn't have zero mental health facility. It does have capacity for some mental health patients. It's just what we're currently providing, we won't be providing. We're currently holding a larger number of mental health patients whilst they're waiting placements, which we won't be able to provide, but recognising there are still patients who, in their initial crisis, will require medical clearance or being brought to a place of safety. There are going to be facility within, so there are going to be 3 of the cubicles within the emergency department will be designed to be appropriate for dual purpose, so for patients with physical health needs, but also for when mental health crisis. They're going to be slightly designed in a different way so they can be supportive of that group of patients. It's just we're offsetting more patients than currently seeing.
Can I just quickly, how confident are you that the local authority will ever play catch up so that patients don't have to be in hospital beds for longer than they need to be? Because most patients want to get back to their home or other care facilities. I mean, are you confident that they will ever get it right?
Okay, I'm not sure I can give a clear answer to that. I think it is a challenge. We have far too many patients in hospital that it's not the ideal place for them. We do need to be able to work collectively with all system partners, housing, social care and others, to get these patients to the right place at the right time. So we know what the length of stay is for patients past their ready for discharge date, and it's far too many days, and we've got to continue to work on reducing that. So if I look at the pathway 1, 2 and 3 patients, use the national definitions, we have a significant number across all 4 of our hospital sites. So we're not where we need to be.
It kind of just emphasises, we are looking at the reconfiguration of A&E department, but you can't do that in isolation. It's social services, it's the police, it's community health, it's the new Prime Minister's emphasis on public health, which seems to have gone out the window these days. And, looking at A&E in isolation without all these other moving parts is kind of a very small focus.
Councillor Parrott.
Thank you for allowing me another question. I think I just want to kind of almost sum up what my thinking is. And, in order to deliver this, you've got 3 big parts here. You've got the environment, which is the build work and all the building, which is massive. And as I said, we know it has to be done. We don't have any choice. Obviously, clearly can't sustain it the way it is. It has to be done. It's going to be painful. It's going to be horrible. But we know we've got to get through it somehow. We've got people, and under people, I would put staff and the residents of this city, residents and visitors of this city, if you like. And then we've got the third party, which is the third part of the triangle, if you like, which is our partners. And under that, we've got SPFT particularly and ASC. And of course, there are other partners there, but they're probably the 2 key players in terms of, your key roles. I guess we've got, I don't want to labour the point, but we've got some serious issues here. We've got massive issues with your partner network. You've got SPFT, which is currently still 59th out of 61 with horrendous problems. They're not delivering. Poor John, every time he comes here, he just cries and, curls in a ball and hopes that I will go away. Unfortunately for him, I don't. He is a very nice man, but, it's a mess. And it's not, it's not great at the moment, and we really have some serious problems. We've also got serious problems with adult social care, which we're aware of. We've got, and things are improving slightly there, but there is a lack of resources, there is a lack of money. Very much your delivery in terms of what you're going to deliver for the city, which doesn't just depend on this building. The building is part of it, and it's like the flagship bit of it, if you like. But the real nuts and bolts of what makes a great hospital is all the other stuff that sits behind it, and none of that other stuff is working. I'd also just like to slightly focus on staff, and you've talked about staff, and it's really lovely to hear people talking about staff, and I agree. As a psychotherapist, I work with many of your staff who come to see me when they're having their own crisis over the years. And, I hear what you're saying, but, both your own hospital and SPFT have been hauled over the coals repeatedly for bullying and bad behaviour and poor management of staff. And I know I had somebody, in fact, in my office this morning before I came here who is on her knees, unable to cope with what's happening and the way, you know, what she's being asked to do. Now, that's not in the A&E department, I accept. However, that is further back in the hospital. But the knock-on impact is huge for you in your A&E department, you know. So we've got complex needs with our residents and our communities, which are only growing and getting bigger. You know, these issues are massive and they're not going away. And I guess I just feel like we've had quite a rosy presentation, and you've answered the questions very well and, you know, very constructively. But I just am left with this feeling of, you know, these problems are massive and they're entrenched and they're not going anywhere. And I guess it's really more of a comment, and, you know, I don't expect you to have any magical wand-waving answers to that. However, I just felt like it would be inappropriate for me not to kind of sum up and say that's where I'm at with this at the moment. So thank you for your presentation on that. I really do admire the work you're doing. That's not my point. But I think, you know, these are the key issues that are facing us all.
Do any of the members have any questions at this point? I appreciate we're well into extra time, and at the risk of giving myself a red card, I think it would be amiss not to ask at least one question from the chair, given most of the members have had the privilege. So bear with. Your presentation is refreshingly honest, I think, about the bricks and mortars not being the solution to the pressures you've got at the emergency department. And I guess my question is, if discharge and patient flow worsens during the build and the building works, what contingency plans have you in place to manage that? That's one question. And my final question goes back to the letter that was submitted by Councillor Alexander at the beginning of this agenda item, which is looking at the involvement of people with autism and dementia and learning disabilities. Have at any point that cohort of people been involved in the design of the acute floor, the waiting areas? Is there opportunity for them in the future to be involved in that? And how will that cohort of patients be supported during any disruption? I think that probably has been touched upon, but I think the primary part of that second question is, if they haven't been involved, is there scope for them to be involved going forwards? And I'll just go back to the first question about any contingency plans. Thank you.
Thank you, Chair. So it's always really important to have a plan B up your sleeve. So on the upside, we're not, just to reiterate, we're not losing the number of care spaces, but it is going to be disruptive. There's just no getting around that. We do have tried and true mechanisms in the Trust, which we often enact, usually during winter, but more recently during a heat wave, that we need to continue to evolve in terms of how we respond to demand of whatever's causing that demand. Now, we'll continue to keep working on those actions in terms of how we make sure that we are responding to pressure inside the hospital, and that could be because of demand, it could be because of all sorts of different reasons. So we've got a pretty well tested processes of doing that, but I am reassured that we are not losing the number of care spaces in the department. I think probably the more important point is your second question in terms of how we're going to make sure that during this building phase that patients, and it's not just those patients who may have a number of different particular needs, but actually patients just generally can cope and manage, and the staff, through a period of disruption that's going to last 18 months effectively. So I think that's definitely going to be quite a challenge. And some of that is around engagement and communication, because actually patients are incredibly forgiving if they understand what it is we're doing, why we're doing it. and what the sort of time frame is incredibly forgiving. So I think it behoves on us to really make sure we've got that communication and engagement as good as we can get it. I think there is some specific further work we need to do, and Nikki, I'm sure, will probably add some more comments around how we do continue engage with some of those groups. And I know Councillor Grimshaw has also been in contact with me about that as well, because she's quite passionate about that. But at any time, we're always really keen to hear and engage with any groups that we may have missed. So if people have got, want to flag any of that with us, please do, because we'll make sure we do pick that ball up and run with it.
Can I just come back? I guess the first question wasn't so much about the increased capacity or the capacity itself. It was during the actual moving from phase 1 to 2 to 3, if you get increased flow or discharge issues in particular. So not so much about capacity, about whether in E&E you've actually got bed blocking, as it were. What contingency plans are there to deal with that?
Yeah, so okay, that's almost business as usual for us, sadly. So we deal with that sort of scenario almost every day, certainly every week, where we have, for whatever reason, we've got increased flow challenges or increased demand or both. So we have a number of different actions that we take in order to improve the discharges and or the flow. Now, some of that is about changing our risk profile around discharge. Some of it is around how we maximise some of the other spaces in the hospital outside of ED to actually create some more flow. We have got extra capacity, extra beds on wards that we will use in those sort of circumstances, for example. So we've got a whole range of different actions that we do, but sadly that is pretty much a weekly experience that we have. Do you want to comment on that?
Yeah, I'll come in just in terms of, I think just some of the practicalities. When we opened AMU, we had experience of moving clinical services into a unit, which within the trust, obviously, we've had experience with the LMB and the moving of wards from the Barry building into the LMB. So there was quite a lot of planning around the AMU as to how those actual move days would be managed. And certainly there's precedent there to make sure that we have staff in both the new and the old area so that we can kind of provide that continuity of care for patients. And in terms of trying to, one of the things we haven't really touched on is the kind of the staffing throughout the phasing and in the final design. Obviously, the department will look quite different. It's just under a 50% increase in floor area. Distances, travel time will be increased for staff. So there is work going on at the moment about how we can make sure that we have the right staff in the right areas to reduce any disruption that's caused from those kind of increased distances. And that's kind of in development now. In terms of the communication, I think that's something we're really keen to develop more. The main kind of disruption in terms of areas going into the construction zone won't start until towards the middle of next year. The enabling works are fairly limited in their impact on the current live clinical areas, so it really is the best part of the year before live clinical areas are going to face any impact from the work. So there's quite a bit of time between now and then where a lot of focus will be given to making sure we get communications right, both with external partners and with members of the public. And I think would be very open to having more involvement and input into that from some of the councillors here today and some of the groups that we've already had some dealings with. I mean, I think in terms of design, hard walls are set for the department, but there's still quite a lot of layout design within those spaces and conversations to influence that we can draw groups into as well. So absolutely some opportunity still before we get kind of the build going to get some further input, and would really welcome that.
Thank you for that. Thank you for your presentation and for taking all the questions you have. I'm now going to ask members if they're happy to note the report. Fantastic. I am going to take a comfort break now. I appreciate we've been here for 2.5 hours. So please take 5 minutes to stretch your legs before we come back to the next agenda item. And thank you very much for coming again, and enjoy the rest of the evening. item on the agenda this afternoon, which is cancer diagnosis and treatment. This paper provides an update on local cancer performance. Nigel Key from the University Hospital Sussex, the Chief Delivery Officer, will present the paper. Over to you, Nigel.
Thank you, Chair. I'm also joined online by Dr. Sarah Westwell, who's consultant oncologist and is also the Trust's lead clinician for cancer services. So thanks, Sarah, and apologies for keeping you waiting. I thought I would just start off by, it's been a few months since I was last here talking about cancer care, so it's nice to be able to come back and give a bit of an update. I'm sure Sarah will add some further comments, but I just thought I'd start off by just again pulling out some of the main points on the slides. I won't go through them laboriously point by point. You've got them in front of you. The good thing to note is that I think last time I said that we were making steady progress, but we were still had some further improvement to make. Again, you can see by the numbers there, we have continued to make that improvement across the three key cancer standards of 28 days, the 31-day and the 62-day standards. However, there is still further work we need to do to make sure that we are consistently delivering those three standards across every tumour group within cancer services, and we'll talk a little bit more about that. You'll see that in terms of the patients on our cancer patient tracking list who are over 62 days, most of the different cancer sites are all doing well and seeing improvement, with the exception of skin, and we'll talk a little bit more about skin, and there is work that has been done across the ICB area around the skin pathway. The next slide, Sarah may want to add some comments around the cancer outcomes and data set, because I think this is an important data set that does give us some assurance around both the extent of the data capture around cancer patients and also making sure that any missing data is kept to an absolute minimum, and making sure that in terms of the holistic needs assessments that have been done as well. So I don't know if you want to add comments around what that actually means.
So I think it's important, obviously, the stage of cancer. So there is a drive across the cancer plan that we are diagnosing cancer earlier in the disease trajectory. So for us to be able to ensure that we're capturing staging of each patient that presents with cancer accurately, then we can start to measure that migration as we move towards earlier diagnosis of cancers at an earlier stage, which are more likely to be curable. And that requires teams coming together, making sure that we're capturing the data in the right place and then able to report that appropriately. We recognise that previously the focus on this area has not been as good as it could have been. So there has been a real drive across the teams in moving towards improving that. And we're doing a lot of work with the Surrey and Sussex Cancer Alliance across our various teams to make sure that this remains embedded within treatments. And it's often captured, but in kind of free text on consultant letters. And it's making sure we're capturing it in the right place. And then this feeds into the National Cancer Audits, NatCan, which are reported publicly and allows kind of comparison between areas in terms of outcomes, but also may help us focus on, are there particular areas within our communities that are more deprived that may be presenting later, and help us work with our community teams to understand what the barriers to presentation are and how we can really reach out to those communities. And then in terms of holistic needs assessments are around our clinical nurse specialist teams reviewing patients very early on in their kind of cancer pathways to look at what are their needs and how do we make sure that we address those needs and signpost patients to the right support and help and information. And it covers a very broad base around psychosocial well-being, financial, nutritional well-being. A cancer diagnosis can have a huge impact on an individual, but their families and friends that can spread far wider than a simple cancer diagnosis and the requirement for ongoing treatment. And again, we recognise that to begin with, our data capture was not as complete as it could have been. So there's been a real focus on making sure that we're capturing the right data and then working out how do we build the teams to make sure that we are reviewing all of our patients and improving their access to that signposting.
Sarah, one of the other pieces of work we'll be doing is also continuing to improve our multidisciplinary team meetings. That are incredibly important meeting that help support the diagnosis and correct treatment for patients on a cancer pathway. So again, we've been working on making sure we've got better standardisation across the whole trust, using technology where appropriate and we're sensible to do so. And obviously making sure that we're optimising the effectiveness of those meetings. Is there anything else you want to say about the MDT meeting, Sarah?
So the MDT meeting is something very close to my heart. Been working with the Alliance across Surrey and Sussex, but also the Royal College of Radiologists. As an NHS, we spend about £600 million a year on MDT meetings, and they were developed in the 90s quite rightly to make sure that every patient with a cancer diagnosis had a multidisciplinary approach to their care. However, they've almost become a victim of their success, and we have a lot of evidence, and there can be many cancer diagnoses that are relatively standard, where we have a very clear evidence base and guidelines. And we recognise that sometimes MDTs may delay cancer pathways. And I think we referred earlier to No Decision About Me Without Me. MDTs are about making recommendations, not treatment decisions. So it's taking the characteristics of the cancer, the staging and any additional patient information and making a recommendation based on national guidance for the clinician then to discuss with the patient to agree that treatment plan. So we're looking at standards of care, which means that we're removing the need, but making sure that we're freeing up time so that those patients with really complex or non-standard cancer cases have the time that is required for those complex discussions, but those patients with relatively straightforward pathways can move through their pathways quickly without delays.
Thanks, Sarah. On the next slide, we've just touched on a few other areas that we have been working on further improvements on. In terms of patients requiring endoscopic interventions, you can see that we've improved from what was a 45.5% turnaround time within 10 days up to the latest figure, which was 76.1. So quite a significant improvement in terms of those turnaround times for endoscopy tests. Patient stratified follow-ups are another aspect. So you may want to add more to this, but again, this is a really useful way of actually making sure that those patients that are participating in patient stratified follow-ups are being followed up in the right way. And in the right time as well. And again, we've given some examples of some specific pathways that that's being used. I don't know, so if you want to talk a little bit about what the impact of that is for patients and staff.
So patient stratified follow-up is really about personalising the care that we provide for patients that they need. It means that patients that need then long-term follow-up aren't necessarily having to not go to work or be able to care for their children, that we fit their follow-up around their lives and their needs. It also in turn though frees up other clinical capacity so that we can move towards faster diagnosis and making sure that we have rapid access to treatment for those patients who are more actively involved in the pathway. And it also allows clear tracking. So, for example, historically, if a patient required an annual scan, the patient would have needed to have been seen in clinic, have the scan booked, then the scan performed and come back, and then come back for that result. What we didn't have, though, was necessarily any assurance that if you did require annual scans, could we assure ourselves that all of the patients that required the annual scans were receiving the annual scans on time? So the patient stratified follow-up allows us to track those patients and make sure that they're receiving their scans. And I think, the next step is even to think about how do we use patient-reported outcome measures, so potentially using Careology or the various apps that are available, recognising that not all of our communities are necessarily digitally able, but actually thinking about how do we also capture some of their symptom feedback, some of their concerns, so that we can do targeted interventions to those patients that need it.
Thanks, Sarah. And obviously, a lot of work's been going on around improvements to our radiotherapy services as well. And it's really good to see that all of our Category 1 patients are being treated within the national timeframes. And we've seen some quite significant improvement in our Category 2 patients as well. We have a brand new LINAC that is currently being installed. And I think, Sarah, from memory, the first patients will be treated on that new machine in September, I think is the timeframe.
That's right. So just for reference, we have 6 radiotherapy machines across Sussex, 2 in our satellite unit in Eastbourne, 2 in our unit here at the Royal Sussex County, and 2 tomotherapy machines at Preston Park. And when we have the new building, which we hope will open in 2029, we'll be able to consolidate 4 machines, possibly with a 5th bunker in that building. But meanwhile, we have to go through a radiotherapy replacement program of our Eastbourne machines. So we are opening a 7th LINAC. As Nigel said, we took delivery of that linear accelerator at the weekend. The Trust has funded refurbishment works in an old linear accelerator bunker, and the machine is now being installed and will go through a period of commissioning before treating our first patients, and that will allow us to expand our capacity across 7 machines for probably a period of about 6 months, to help us recoup some of our backlog of patients that are waiting longer than we would want them to wait before we start that radiotherapy replacement program across all of our machines and put the new machines into the new building. I think it's also fair to say, Nigel, we have had challenges over probably the last 7 years with being able to provide care for our patients with head and neck cancer in Eastbourne. So patients, often some of the most deprived patients with head and neck malignancies, have historically had to travel to Brighton, so pass by their local radiotherapy unit in Eastbourne to receive specialist care in Brighton. And many centres actually do concentrate that specialist care because it is very complex radiotherapy. Patients need a lot of support from dietetics, speech and language. They often need tube feeding. But the Trust has invested in supportive dietetics and speech and language support for patients. And we went live this week with the ability to now treat patients with head and neck malignancies in our Eastbourne units. And the other thing to say is we're opening a new superficial radiotherapy machine. So that's for patients with skin cancers, to remove them from our bigger linear accelerators to give them more specialised care with a new superficial radiotherapy machine, which will again free up capacity on our linear accelerators to treat those patients, but also provide specialist care for our skin cancer patients.
Thank you. And just to join a couple of dots here, our 31-day cancer performance is driven really by 2 aspects. One is radiotherapy, and the second one is timely access to surgery. So obviously the improvements we made to radiotherapy will absolutely support our improvements in the 31-day cancer standard as well. I did briefly mention around the success of the consolidating of the lower GI surgery service at Worthing, and it's really heartening to see that since we've done that, not one patient has been cancelled for non-clinical reasons since we've done that. So that's really good to see. So clearly, I think that it's delivering a much better, much more reliable service for those patients with much greater certainty. A lot of work has been done around demand and capacity for skin. We are using some AI called Skin Analytics, which helps make sure that patients who have got non-cancerous skin conditions can easily be carved out and treated and sorted, so that the staff can concentrate on those patients that are on a skin cancer pathway. Obviously, we do get some seasonal variation in the demand for skin cancers, with this warmer summer months typically seeing an increase in that demand. And there's quite a lot of work going on around how we increase the capacity over those months to be able to better meet that demand. There is a recovery plan for skin that has been developed, and it's got both short, medium, and long-term actions that are being put in place to improve our skin cancer performance. Is there anything else you want to add around skin cancer, Sarah?
No, I think as you described, Nigel, we've had some significant challenges. We have a population that's rich in skin cancer by virtue of our aging population and also our position on the south coast and our location close to Gatwick. We have a lot of air crew as well. And I think the new clinical operating model across the organisation will really help us to consolidate our capacity across the legacy West and East teams. I'm supporting with a skin workshop tomorrow. We've established pathways with through the Alliance, looking at how we optimise AI. At the moment, we are bringing patients into secondary care to be able to photograph and use AI to rapidly reassure those patients who don't have malignancy. But I think, again, looking towards the future, it's how do we start to put the AI technology into primary care so that patients coming into secondary care are those who require secondary care support. So I think, there's a huge amount of work going on. And whilst you've seen those stepwise improvements, nobody's resting on their laurels, because there is still further room for improvement and really embedding good capacity and being nimble, because actually what improvements we make today, we may need to make different improvements as we morph and change and support our communities over the coming years.
Thanks, which is a good segue just in terms of some of the future things that we're doing. Obviously, we've got the NHS Cancer Plan, which we're absolutely involved with. Radiotherapy we've touched on, really making sure that our cancer workforce is fit for the future, optimising those pathways, and lastly, around building some of the inequalities into our daily works and making sure that the way in which we communicate with patients is in ways in which they can understand and relate to, looking at some of our frailty aspects, and quite a lot of work around the lung cancer screening as well. And then lastly, I'm going to give Sarah the last word around the new cancer centre, but it was an absolute pleasure and a privilege that Sarah and I were both there in the official foundation stone ceremony on in May, and it was really a fantastic day and great to see. But Sarah, you might want to talk about what the new cancer centre is about.
I assume that many of you know a little bit about the new cancer centre, but as you can see from the photographs, we are now well on the way to building a £250 million new non-surgical cancer centre for the population of Sussex. And I often describe the cancer centre not as a building, but a being. So we support our patients across Sussex, as far east as Hastings, and as far west towards our population in Chichester. And this building is about providing care for its local population, but also for providing specialist care for patients across Sussex in terms of tertiary cancer care. So the footprint, I don't know whether any of you, we've talked about the poor estate relating to A&E. I'm sitting in a room at the moment with a lot of fans, and it's about 43 degrees here. And so this new building will provide a state-of-the-art, purpose-built a building that's been designed with the input from our patients and from our staff, describing what it is that they would like from a building. And we've talked previously when we're talking about A&E, but this is about using light, natural sources to try to support a calm and healing environment, a space in which staff want to come to work and feel able to do their jobs, but also where patients feel comfortable, confident, and receive excellent care. And I think it helps us in terms of pulling in the best of the best across the country. We want to attract excellent staff that will drive and support us in our drive to improve our research and innovation for our patients. So it's 5 floors. As I said, there'll be a radiotherapy department on the lower floor with 5 linear accelerator bunkers, a specialist brachytherapy theatre suite for delivering internal radiotherapy for patients with tumours such as prostate cancers, and our superficial radiotherapy machine with specialist mould rooms. Then on the next floor, I'm having to remember this now. Then on the next floor, it's our outpatient department. So an expansion of our outpatient capacity. And again, thinking about those waiting rooms and spaces, we've designed on the next floor up, it's actually predominantly plant, but our patients fed back to us that when they attend for counselling and support sessions, they find it quite hard to go into clinical areas. So that floor will also have a dedicated area to support psychological counselling and support, which will be very different to the other clinical areas and away from those clinical areas. Clearly, it's in the same building. We do have counselling and support at our Horizon Centre, which will be in a separate building that I'm sure you all know. Above that will be a 36-bedded individual room, ensuite for some patients, negative pressure with 2 bariatric rooms and areas dedicated to teenage and young adults. And then on the top floor, we'll have a brand new treatment unit with chairs designed in specialist places, in specialist spaces to give patients more privacy. And we'll also have a 10-bedded cancer assessment unit. So again, we've talked about patients coming to the right place. We recognise that at the moment our patients predominantly present through the emergency department when they have symptoms related to cancer or side effects related to treatment. And ED is the last place you would want to go if you're receiving treatment for cancer. You don't get specialist care. You wait a long time, you're in with lots of other people at a time when you feel very vulnerable. So for us to be able to provide our own emergency specialist care unit for patients, and also for those patients where we might not need to admit them to hospital, but they need daily ambulatory care with injections or treatments or care to support them, they can come into that unit. And that will be revolutionary for the patients of Sussex. But we've built it around pathways so that we can make sure that we mirror those in a hub and spoke way across our other units in Sussex. So again, the mothership with support in the very specialist unit, but providing that outreach care to our other units across. And we're talking about our treatment units. We have a brand new treatment unit in our Worthing site, the Amberley unit, which is a real improvement on previously. We've got a unit at the Princess Royal, we've got a unit at Chichester. So again, it's about providing care as close to home as possible for each of our patients and that specialist care in this centre. So the building is well on its way. They're pouring the floors for the radiotherapy units in September. September's a big month for radiotherapy units. And the new modular build will mean that we should see that building starting to go up now quite quickly. So it's exciting times.
Thanks, Sarah. So hopefully it gives councillors a bit of a sense of our continued improvement journey and with lots of really exciting things for the future as well. Happy to answer any questions.
Thank you, Nigel, and thank you for the presentation. A question from Councillor Evans.
Thank you, Chair. Thanks for the presentation. Excuse me. Couple of questions about things you sped through. It sounds fantastic. The new building sounds amazing, and thank you for all that information about it. But a couple of things about the current situation. Good to hear about the success of the moving the LGI surgery to Worthing. I think we asked some quite concerned or possibly even cynical questions about that move when it came to hospital previously, and it's good to hear that it's been a successful thing. So I think we were a bit worried about it, if memory serves. But I wondered if you could tell me a bit more about what that sentence means, because I'm not medical, about still work to do in the middle part of the pathway, diagnosis to decision to treat, because I don't really have much of a clue. In my mind, as soon as you're diagnosed with cancer, surely there's a decision to treat, unless you're immediately known to be terminal, I guess, would be the only circumstance I could think why you wouldn't make it. Like, why is there a delay at that point? I just don't understand. So that's one thing. The other thing is, I wondered if when you went through the future plans slide, I'm glad to hear, and Sarah said in her when she was talking about the difficulty of reaching, you know, how people from deprived communities tend to present later, and so we're concerned about equalities, and Sarah said that you were looking to find out what the barriers to presentation are, and that's very laudable, but I was just slightly nonplussed by the plain English letters remark, because I'm just wondering, do you have some evidence you could share with us that says that part of the picture in poorer areas presenting later is that patients don't understand the letters? Because it's not something I've ever seen any evidence for or heard of, and I was a bit
Shall I answer
offended
those
and
questions?
nonplussed. Thank you.
Thank you for the questions. I think the first question you talked about the middle of the pathway. So cancer is complex in its treatment, but the current constitutional standards are around the 28-day, 31-day and 62-day standards. And the 28-day standard refers to the period of time in which the target is that patients either are reassured that they don't have cancer or are informed that they do have cancer. And the kind of gold standard is that we should be meeting about an 85% target at the moment, and our FDS performance is sitting at about 80%. So we've definitely got some room to improve. You could, for example, if you were referred with problems swallowing, you could be seen immediately and have an upper GI endoscopy. And at that time, that upper GI endoscopy identifies that there is a cancer there that is biopsied. And you are informed at that time that you have a cancer. However, we still need to wait for the pathology to be reported. We would then need to do a CT scan. We then need to do something called an endoscopic ultrasound, which would be an ultrasound to look at the lymph nodes. We would need to do a PET CT scan and potentially something called a staging laparoscopy, which helps us gather the information around the stage, the biology of the cancers, the molecular marker of the cancer to determine a treatment plan. And that diagnostic process then takes some time. And that's the bit that people refer to as the middle part of the pathway. And some pathways are much more complicated than others. And then when you've got all of that information and it's been discussed in a multidisciplinary meeting, there is a treatment recommendation. And you then meet with the patient to discuss all of that information and go through that treatment recommendation. And that's when you have your decision to treat. And then from your decision to treat, the gold or the constitutional standard is that there is a 31-day target. The 62-day target refers to the fact that from diagnosis from your GP on an urgent suspected cancer pathway to receipt of the first treatment should take no longer than 62 days. So whilst we might hit the 28-day faster diagnosis standard, because there's only about a 6% conversion on the urgent suspected cancer pathway, you can hit that standard by telling everybody that don't have cancer that they do not have cancer. And what we really have to do is lift that performance in those patients that do have cancer and then bundle up the diagnostics and make sure that we can streamline those diagnostics so that we can get to that point where we can make the decision to treat. Sometimes we only have 4 days for our 31-day bit of the pathway, because if we're making a decision to treat on day 58, we have to get that, we have to then try and get that treatment in by 62 days. So the lower GI pathway, for example, and we do have challenges around our frailer populations because they struggle to go through colonoscopies, and we've developed a frailty team looking at making sure that we're doing the right tests for the right patients so we get the right answers, and we don't have patients, I suppose, hovering around the middle part of that pathway. So the middle part really refers to that staging investigation so that we can decide upon the appropriate treatment plan. Does that make a bit of sense? I think in terms of reaching hard to meet populations, there are so many elements to that. So, for example, our breast screening. Our breast screening teams often produce patient satisfaction surveys for me. And the problem is they survey the patients who turn up. which is really important because we need to know, are we providing a good service, because we want them to come back next time, and we need to know how to improve for those that do. But really importantly, we need to know why those that didn't come, and that's the really important aspect. And they're the next steps on, a highly performing cancer team starts to ask those questions and ask different questions. And there will always be some and some, because we have different pockets of populations with different needs. So we need to get out into our communities and work with the ICB and the Alliance and our voluntary sector to understand how our different communities work and what the barriers are. And there's a lot of work that's been done by CR UK, for example, looking at colorectal screening uptake. And really thinking about how do we target our different communities so that we meet their needs, because there isn't a one solution fits all. And I think the other thing is around, I suppose, targeted screening. So breast screening obviously is open to all. Targeted health lung screening has been a massive success, and that's really going to those people who are most likely to have lung cancer and targeting the screening. And in doing so, we've diagnosed a significant number of cancers, but 75% of them have been diagnosed at an early stage. And our biggest challenge as a country is that most lung cancers are diagnosed at a late, incurable stage. So that stage shift to moving it earlier to a curable situation is massively helpful, but also really targeting that population who is most at need to be able to receive it. And in terms of the comment about plain English, I shuddered when I read it just now. I think it is a massive faux pas that it was on there, and I'm not entirely sure. Nigel and I, the slides were supported for Nigel and I. I think what the individual was trying to say was understandable language, rather than plain English. I think it is a very clumsy description, and I wouldn't want. We need to provide communications in the way that our patients need them. And again, one size doesn't fit all. We need to understand what does the patient in front of us need. I saw a patient today, for example, and she was partially sighted. She was elderly. She didn't have a computer, and we found a little room, and I set her up, and we ran a little podcast for her to listen to understand. So it's about how do we adapt and meet the needs. So I apologise for the clumsiness of that bullet point. It would not be as I wish.
Can I come back on that, Chair? Thank you very much for that. The explanation of the middle bit of the pathway is very helpful, and so is your reaction to that sentence, because that was pretty much my reaction too. I think it's entirely laudable, as I said, that you want to find ways of reaching any hard to reach patients in whatever way works for those groups of people. But it's not at all helpful to be implying, as I think that particular line does, that people in deprived areas are somehow a bit stupid and that all you have to do is patronise them or make things a bit simpler for them and they'll all turn up.
I agree wholeheartedly.
Councillor Parrott.
A couple of points, actually, I just wanted to raise. Skin cancer, obviously, a huge problem. Obviously, skin cancer is now, the biggest group is 75 pluses, for all the reasons, probably, a lot of sunbathing and not much understanding in younger people. Obviously, they are a group that are more likely or have more incidences of digital exclusion, and I just really want to emphasise that we really need to be thinking about how we're reaching our more elderly population, and people aren't just digitally excluded because they don't know how to use a smartphone. Obviously, they might be digitally excluded because they live in areas where there's poor access, partially sighted, I'm partially sighted. It can often be very complicated. The other thing I want to say, and it kind of matches with that, is that for all patients really, is the complexity of managing when you get a diagnosis of something like cancer. And my husband's recently been diagnosed with quite aggressive sarcoidosis, which I know isn't cancer, but very similar kind of prognosis and outcomes in some respects, with a lot of drugs and a lot of appointments. And we're talking about huge amounts of screening, blood tests, ongoing tests and appointments. managing that becomes almost a full-time job. And, there is something about the way we are reaching, the way we are connecting with our patients, which makes managing all of that an added complication. And I'm sure you have vast quantities of missed appointments, missed screenings, missed follow-up appointments, because people don't really get it. Not because they don't get it, but because they're not getting the information and aren't able to manage everything that's coming at them in one go. It's a huge amount. I know for him, the one thing that has really helped actually has been having a named nurse that he can go to, and he emails her with any questions or any appointments that he's not sure about or doesn't understand, and she sorts that out for him. And that has been, that's transformative in terms of actually him managing. And by the way, he's a very tech-savvy man. He is part of the, the health and social care department, currently looking at how you transform all your AI and all your digital technology. So he's not a digitally excluded person, and yet he's found it very complicated to manage and to keep on top of. So, I would again raise that, because I'm very concerned that obviously skin cancer particularly is that group, and we do have digital exclusion, significantly in that group.
So just to reassure, the AI element of skin cancer management is the patient doesn't do anything on any form of digital thing. So the AI element is that the patient presents and has their lesion photographed, and then we use that digital AI technology to help us basically understand whether or not this lesion could be cancer, and therefore we make sure that the patient is seen, or whether actually the appearances are benign and the patient can be reassured. So just for that reassurance, there is no expectation that the patient is operating the digital thing and making the diagnosis themselves. So it's something that we do on behalf of patients. I think your comments around the complexity, we've designed hospitals and cancer pathways around doctors and nurses for far too long. And we really, really do need to understand, being a patient can be a full-time job. By the time you've queued up in a pharmacist and collected your prescriptions, had your blood test done, waited for a CT scan, had a CT scan and waited in the waiting room, then come to see your clinician only to be told your scan is not reported and you need to come back again next week. And there is a huge amount that we need to do in terms of how do we make that care more accessible, more feasible for patients. One of the things I recognise is, because of our improvements in cancer care, and as you've described with your husband, and I'm very sorry to hear, some of these diseases are chronic diseases, and patients, do this day in, day out, week in, week out, month in, month out, year in, year out. So it has to fit with life. And we really do need to do a lot of work around how do we make sure that patients have access to blood tests. I'm mindful that changes in primary care mean that patients can often, in some areas, no longer go to their primary care physicians or their units to have their blood tests done. And I think that is absolutely a work in progress about how do we design our pathways around patients and patients' lifestyles. And again, I'm back to one size doesn't fit all. We were talking previously, weren't we, around, we run a 5-day service, 9 to 5, Monday to Friday, but patients have families, they have caring responsibilities, they have jobs, and actually they probably want to be seen at 6 o'clock or on a Saturday. And how do we build that care around those patients? So I think it's not an easy fix, but it's absolutely within our sights and within our plans to work with patients to work out how we do it better.
And just to add, I think I would also include carers, family members as well. I mean, I lost my own partner 2.5 years ago, and I'm a nurse by background, and I felt overwhelmed. So I absolutely understand.
Councillor Simon.
Sorry, Chair, I didn't quite hear you say my name. Just so that I can understand, and then I have got a question about skin cancer. Can you just remind me, what do you mean by MDT? And
Sorry.
Sorry.
Multidisciplinary team. So, for example, that might involve a physician, a surgeon, an oncologist, and that would be a medical oncologist, a clinical oncologist, radiology, pathology, our clinical nurse specialist teams, our palliative care teams. So that kind of multidisciplinary approach to make sure all of our specialties are providing input into patient care.
Yeah, thank you. And you did. I believe you tried to explain patient stratified follow-up. I didn't really understand. Am I right in thinking that that basically means thinking about the needs of the individual and how to follow them up, or have I missed something?
No, not at all. So again, a lot of our pathways around cancer have been built around how we treated cancer 25 years ago. So patients may have had a cancer diagnosis. Our survival outcomes were not as good as they are now, and our treatment options for patients with advanced, treatable but incurable cancers were not as good. So many patients who've had treatment with the intent of cure may then need to go onto a surveillance program. And again, historically, patients might have had annual follow-ups to go and say hello to a consultant. And the reality is that those follow-ups deliver very little for patients, and they deliver very little for the society and the system on the whole. The risk is that patients might have a symptom and actually they go, well, I'm going to see the doctor in 8 weeks' time, so I'll sit on it because it's really hard to get through to anybody. So I'll sit on that symptom until I go to see them. So patient stratified follow-up was really around streamlining to make sure that those patients that need surveillance imaging or surveillance regular blood tests, we can assure ourselves that they're definitely having them and we're monitoring them and they're having them regularly. It's also though around avoiding unhelpful follow-up appointments that cause stress, might delay diagnoses, but freeing up capacity so that we can improve as we described, the front end of the pathway. Our clinicians can see patients who need treatment, but also those patients that do present with a problem, they can pick up the telephone and be in clinic the following day because we've freed up that capacity. Now, that's not for everybody, and the reason I love my job is because no two people are the same. Everybody has a different need. So the kind of personalisation of care is what is right for the patient in front of us, and how do we provide that follow-up with the assurance that we're providing the surveillance care that they need, but they have rapid access to the specialist teams when they need it, whilst freeing up capacity rather than having clinics. It's about, I suppose, making sure we're not providing unnecessary follow-up.
Thank you. And then my specific questions around skin cancer is what is it? You've kind of outlined a little bit why it's a bit of an outlier here in terms of being quite poor. Is that and obviously we've got an ageing population, but so is everywhere else. Is our population more ageing than other areas? Is skin cancer a kind of a general national problem because of that? And I've got a specific concern about AI in terms of diagnosing skin cancer. For context, I've had a malignant melanoma, which I diagnosed myself, and my GP told me it wasn't. So I'm not a very trusting person because of that, because I wouldn't be here if I hadn't trusted myself. So are you, in terms of AI, I'm concerned that you might not be teaching AI with the atypical apigmented melanomas, and if a patient is diagnosed by AI and told that everything's fine, is there an option for them to say, yeah, but I don't really trust that because...
So in terms of AI is highly validated, and I think the thing that you describe, human beings make mistakes. And actually, as you describe, melanomas don't always present like a textbook presentation. So the way is, again, not everybody has an AI appointment. So if something very obviously looks like a melanoma, it doesn't go through an AI pathway. It goes straight to a human being. And the thing about the AI is if there is any doubt that it could fit into all of those atypical characteristics, it goes, I can't tell you, and I cannot reliably tell you this is benign. So go forward in that pathway. So it's about, and the validation of the skin analytics tool, this is a tool that is being adapted across the NHS. It's not just something that we're trialing in Sussex. So it's again, challenges around skin cancer prevalence and incidence is increasing across the country. So more and more people are presenting with symptoms concerning for malignancy, and the pathways are overwhelmed by the numbers of patients. So, and we still have a kind of 6% conversion rate. So that means for every 100 patients that are seen, 6 have a malignancy and 97 don't. So how do we make sure that we use our resources so that patients who do have a malignancy get seen by the right people and also get the treatment that they need, whilst reassuring patients, you're absolutely right. You can ask to see a human being. There are really tight criteria around people who are suitable for going through that AI pathway. And the other thing to say is the feedback from the information that patients receive after a benign diagnosis about what to do if you are not happy or if anything changes, and the signposting is really it's really quite good. So it's not so you haven't got a problem. It's if these things then happen, this is what you do. And I think for me, sometimes if a human being tells you something isn't something and you really think it is, you don't know really necessarily where to go next because somebody's told you it's okay. And the AI tool actually is, we don't, this doesn't look like a melanoma, or it doesn't look like a malignancy. However, if any of these things happen or you're concerned, come back.
Okay. That's reassuring.
I was going to say, one of our challenges is that no tests or human beings have 100% sensitivity and specificity. And that is a difficult, uncomfortable truth.
Yep.
And therefore we will never find it, or we haven't found any test anywhere yet that is 100% specific and 100% sensitive. Skin analytics is 99.95% sensitive. So in other words,
good-ish.
So, and we don't actually know what our human being sensitivity is, if that makes sense.
Yeah. Okay. Thank you. And could you answer so is this a national? Are we in an outlier, or is this a national issue?
So it is a national issue. So the prevalence of skin cancer, the incidence of skin cancer is increasing year on year. Somebody has referenced earlier, I happen to be a melanoma oncologist, and the reason I'm not with you in person today is because I've had a melanoma clinic today. So melanoma is something that's very close to my heart. The incidence of skin cancer, as I said, is going up, and in part that is due to our ability to access sunshine and our behaviours in the sun. So many skin cancers are UV related. So our climate is getting hotter. Our behaviours in the sunshine and probably not quite in the space that behaviour in Australia is, for example, where they have much better education around how to behave in the sunshine. And some of these behaviours were what happened 20 years ago. And it was a time of package holidays and being able to really access the sun and get out there. And I don't think our population is well educated about melanoma and what to look for and what the risks of melanoma are. So I think there are definitely some challenges, and I'm sure you and I will both be horrified walking along Brighton seafront this week as we see people roasting their bodies in blatant sunshine. So as I said, yes, aging population, but we have a very young, melanoma has 2 peaks, one in the very young as well. So some of my youngest patients are in their 20s, as well as that older peak of population. I think the other thing to say is skin cancer is really subject to seasonal variation. So for many cancers, you might see variation in presentations. For example, if a celebrity is diagnosed with a malignancy because everybody hears about it on social media, and then they present, the presentations of patients concerned that they may have a skin cancer doubles, almost trebles in the summer months. And being able to provide that flexibility of capacity is really challenging. Because at other times of the year when people keep their clothes on, we have a lower demand. So and then you build up a backlog that you can't quite recover. So our real challenge is, how do we cope with that variation in presentation with the seasonal demand?
Yeah, okay. Thank you.
Councillor Winder.
Thank you. I just wanted to ask about trust in the processes that people get caught up in. So they may they may go for screening, but they may sort of lose confidence in that after a number of years, for example. And maybe if they've got a family history, that they might do it for a period of time. And then how do you make sure that people still retain that confidence in keeping on being tested and checked to make sure for 20 years or 25 years or something, and what sort of information would help to keep people on board with how important that is?
So I think that's a really good question. I think it's a question for us as a nation, as well as for kind of our local communities. I was reflecting the other day, I'm of a certain age, I've passed my 50th birthday, but bowel screening, breast screening, why don't we bundle them? Why at the moment you get sent an appointment this and then you get another appointment, and if you're a busy working person, it's hard to be able to access those things, and there are different barriers for different people in terms of whether they're working, can't take time off, they're carers. They don't trust the system as you describe. So again, it's about getting out into our communities and understanding what are the barriers. How do we, bowel screening, for example, the reality is somebody has to put a little bit of poo on a little piece of card and put it in the post. And different people will have different levels of comfort about being able to do that. So how do we overcome that with certain communities so that they feel more confident in doing it? Some communities are more suspicious of medicine, of conventional medicine. The mammogram, it's uncomfortable. Going for lung screening, it's scary. There are lots of cervical screening is very uncomfortable. How do we get there? So I think there's a lot of work that we need to do with our different populations. I think we do need to think about, could we bundle screening? And the other thing is around, how do we distribute information about health and well-being? One of the things we haven't talked about, we talked lots about treatments and diagnostics, but sleep, movement, quality of diet, etc. How do we get all of that information in a safe, consumable way to our various different populations? And I think it is a difficult problem, and it's definitely a work in progress. But I think there is some work to do about thinking about what are the barriers and how do we get there.
Yeah, thank you for that. And just as a follow-up, do you think it's something that could be enhanced within community groups, or people who get together in different groups and maybe more making health hubs more accessible, perhaps?
Definitely. I think I worked in the Alliance on some targeted prostate cancer screening. So our kind of Black African community are at a higher risk of developing prostate cancer, but they're also a community that are most likely to present late, and they're gentlemen of a certain age. So, they don't really like to trouble the medical health professions. So with the Alliance, we did some targeted work and used gentlemen from the same cultural backgrounds to go into their communities, into their community centres, and talk about it and make it normal and make it okay, and bring patient experiences. If you recognise yourself in somebody that's talking to you about a problem, you're much more likely to be trusting than having somebody from a different cultural or ethnic or socioeconomic background talking to you about a problem and what you should do. So So that kind of real targeted focus of how do we reach those individuals, but using and being supported by, as I said, the voluntary sector or individuals within their own communities that have had experiences to reach out.
Thank you very much.
Jeffrey.
Thank you so much for your clear explanation of everything. From a personal point of view, one of my closest friends has just been diagnosed with terminal cancer.
I'm sorry.
And all that middle bit that Councillor Evans was talking about, it seemed like an age, but it was one department talking to another one to determine what was the treatment outcome or whether there was a treatment or not. And she has refused chemotherapy, but she'd rather just manage pain. So the system does work. That period between initial diagnosis and getting a treatment plan or not in place is anxious making. But I wanted to pick up on something you were talking about. The King is well known to have had prostate cancer. I wonder why there isn't a normal prostate cancer screening program as there is for breast cancer for women. Surely that is something that needs to be put in place. We've got a health modernisation plan going through. This is more about organisation than treatments. But why are men sidelined when it comes to prostate cancer?
That is a burning question, and I think it's a question that will continue to burn for some time. So in order for there to be a helpful screening program, you have to have a test that reliably reassures people who don't have cancer and reliably identifies that those that do. Otherwise, you spend your life investigating patients who don't have cancer just in case they have, because the test isn't particularly specific. And the risk is what you don't want is false negatives, false positives, so that we're missing patients with cancer. And then you need to be able to pick up the cancer in an early way so that you can treat and cure. So in other words, there's something called a lag phase. So if we diagnose a cancer 3 years earlier, do we actually alter the survival, or do we just diagnose the cancer earlier in the trajectory? So prostate cancer is slightly different or slightly difficult because PSA is not a particularly reliable test. It can be, but it's not particularly reliable. So it can worry people without prostate cancer, but it can also miss men with prostate cancer. And the other thing is, prostate cancer is not one disease. So some prostate cancers are very high risk and they have a poor outcome. And some prostate cancers, as I describe, people die with them rather than from them, and they never require any treatment. So we have some way to go to really develop a test that is sensitive and allows us to pick up those cancers that do need treating, so that we're targeting treatment appropriately for those patients that do, and we're not treating a lot of men who will never need treatment for their prostate cancer. If you were to biopsy most 85-year-old gentlemen's prostates, you probably find a bit of prostate cancer in there, but they will never necessarily know about it, and they will leave this earth with it rather than from it. So we've still got a little way to go with prostate cancer. I think there is, and that remains a national challenge. There are some other kind of multi-gene detection tests. So that's doing a kind of blood test, we call it a liquid biopsy, and you look for circulating DNA from cancer cells. And you might recall the NHS had invested in something called a Gallery test, which was looking at picking up screening for many different malignancies at the same time. So I think there is more technology to come, as we really need to look about how do we enhance our screening and target our screening so that we diagnose cancers at an earlier and curable stage. I don't think I've answered your question very satisfactorily, but I hope I've given you a bit of insight.
Well, I'm a gentleman of a certain age, I guess, so it's a personal interest. But
yeah.
If I ask for a prostate cancer test, I'm likely to be pushed away saying, "I know you don't need to worry about that." And I'm sure women who are offered breast cancer screening are also often reassured to say there's nothing there, or a lump is actually benign and not malignant. So why it doesn't apply to men similarly?
There's a bit more evidence around the breast cancer screening in terms of its sensitivity, specificity, and improvement in survival outcomes. I think we have a gap that we have, as I said, I think we've got some way to go with enhancing our screening techniques. And will it be a blood test? Will it be a urine test? And that blood test actually may be the new technology is looking for circulating tumour cells rather than measuring a kind of biochemical marker, which is not quite as sensitive as we would want it to be.
Technology will catch up eventually, I guess.
Do any other members have any questions? Councillor Hill.
Just a brief comment on Jeffrey's point. I guess I have the best or worst of both worlds, and I guess I'm both susceptible to prostate and breast cancer. So, yeah, just something to bear in mind with making sure that you get different populations included in screenings and other processes for that. So you mentioned lots of patients in their 20s getting melanoma locally. And so I think obviously there's an aspect there of public health messaging that it sounds like perhaps isn't getting through to people who don't understand the risks they have at a young age of melanoma. So are there more things? Obviously, you know, public health comes under what part of the council's responsibility is. So do you sort of discuss and liaise with our public health team in terms of recognising that, you know, it sounds as though we've got populations that aren't aware of the risk, and that's showing up in our data. So I'm wondering, is there sort of sharing of that information and data that's happening in a sufficient way between both teams? And are there other things that could be improved in terms of how we're using our public health spending to, focus on this issue, which is only getting worse, as you say, with the weather getting even more extreme?
So you're absolutely, again, I think one of the reasons, so as Nigel explained, I have a new role. So I started on the 1st of July as the medical director for cancer. And part of that role is much more around a strategic view and how do we work with our communities in the ICB, as well as deciding the pathways within secondary care. And one of my other roles is I'm one of the medical directors at the Surrey and Sussex Cancer Alliance. So we definitely need to play an advisory role in how do we get that public health messaging out there? How do we do our prevention piece? And the difficulty in secondary care is prevention, as you've described, is around public health messaging, social media. We've just done a huge piece in the Alliance, for example, around cervical, so HPV vaccination. So for those of you who don't know, HPV is human papillomavirus. And a programme to vaccinate children was launched probably about 10, 12 years ago, and it started to vaccinate young females at school age about 13, in the knowledge that eradication of HPV would eradicate cervical cancer. And you may have read in the headlines that for the first year we've had no diagnoses of cancer in the 24 age group. So actually that kind of prevention piece. We also know that HPV cancers are related to oral malignancies, and so now we are vaccinating young boys, but there was a period of time where we vaccinated girls and not boys. So there has been a big campaign on social media with universities to do that catch up and vaccinate those boys. And you really need to try and vaccinate these individuals prior to sexual activity, which is why we're doing it in school age. But thinking about how do we do that public health messaging for the preventative piece. So yes, I think my role will be about working with the ICB, working with primary care as well, to think about some of that messaging and feeding back our experience. One of the things, you know, we're talking about prevention, early diagnosis, faster diagnosis. And then at the other end, we've also spoken about that population who present very, very late on. And their first presentation is an emergency inpatient admission when they have an advanced malignancy. And how do we shift the dial and get the messaging out? One of the things that we've launched, headed up by one of our oncologists, Sorsha Dolly is something called the non-specific symptoms pathway. And that is a pathway where patients might not present with a very clear rectal bleeding or a cough or a breast lump. They just present and the GP is worried about there is something going on and they don't know what it is. And that provides that rapid diagnostics. I think your other point you made incredibly importantly is around remembering our populations who may have been female or male at birth and making sure that they have access and are able to access comfortably our screening programmes appropriately.
Geoffrey.
Yeah, just a quick follow-up on public health. Why on earth do the government still allow tanning salons? You're talking about...
Oh, don't get me started.
Well, I will. I'm pushing the button because it's like a public health emergency and we're allowing it in our high streets and people are being invited to give themselves skin cancer.
Smoking, but there's lots. Yeah. Yes, no, don't get me started.
Okay, we'll not. Does anyone members have any questions? Okay, then I wish to thank Nigel and Sarah for presenting and taking questions. I now ask members if they're happy to note the report. Thank you. We're now going to move on to the final and third substantive agenda item, which is NHS change, the ICB update. This paper will be presented by Tanya Brown-Griffith from NHS Surrey and Sussex. I invite Tanya to come and present. Thank you.
Have I got the graveyard shift or are we still awake? Should we jump up and do some exercises? No, because then we'll stay longer. We don't want to. I'm a physiotherapist by background, so you probably will be here doing exercises all night. Right, so I'm going to give a brief overview, and I think HOSC members will note that these are a series of updates around the changes that the NHS is undergoing, specifically the ICB. So since the creation of the new Surrey and Sussex ICB, 1st of April, I did an update as to what that would look like. And we've now been in operation since then. So we've had a first quarter of getting staff into post. We're still going through our expressions of interest for very few roles. So maybe about less than 10% of roles are left to be appointed to. So most roles have been appointed to. Alongside managing that sort of transition, we do have a new operating model. And again, colleagues and councillors will sort of be reminded that this is a national programme about streamlining and ensuring that ICBs are much leaner, but also more focused on strategic commissioning, stepping away from delivery, and also in terms of monitoring progress in pathways and moving to more looking at outcomes, population need, and reducing inequalities, which we know many areas where we've not made significant improvement. And one of the key areas about ensuring that the ICB is focused on sustainable longer-term commissioning and therefore sustainable healthcare provision. So to that end, we all had to, so all ICBs and we in Surrey and Sussex have produced an integrated needs assessment, which we did jointly with Public Health across Surrey and Sussex. All of our public health directors were very much involved with their teams on looking at the needs of our population and very much down to data, but also insights. And I know you mentioned co-production and listening to the public and certainly looking at patient feedback and input. So part of the integrated needs assessment included that would have been fed through the joint needs assessment through public health, which had a patient and participatory group involved in some of that insights. We do have an insights bank on the ICB website now, which includes all the sort of captured data from public forums, patient forums, VCSE sector-led forums, so that we have a sense which communities have been engaged with and where the gaps are, so that we don't over-engage one particular community and then miss out on engaging with another community. And we're trying to do that more equitably now, and not just those who come forward, but those that we don't reach and we don't deliver services to meet their needs. We used our integrated needs assessment, and as you recall, last time I updated that we were just drafting our 5-year strategic commissioning plan, which we needed to submit to NHS England, which we did in February. We've had feedback on that. We've made a few tweaks, but we now have the strategic commissioning plan published on our intranet, and will be published on our internet shortly. Alongside the commissioning plan, we now have to develop an implementation plan, because a strategy is a strategy, just outlines the vision and what we hope to achieve. What we now need to do is have a plan that will work. And so internally, we're having lots of debate about how we prioritize the 12 things that we've outlined in our strategic plan, and what we start with, and how we put a clear trajectory year by year over the 5 years as to what we will be seen to improve, and how we measure and monitor that, because it's no good putting, again, some actions in place if you don't monitor the impact. So we're going to be working with all our stakeholders over the coming months, so over end of summer to the early autumn period, holding workshops with partners. And I know members of the public will also be part of that sort of engagement, and then we will publish an implementation plan by September, October time, which will then be published at that point. So the implementation work will focus on neighbourhood health, which we've mentioned several times throughout the conversations this evening about the importance of ensuring that our community provision meets the need, and therefore those who require urgent and emergency care have the capacity to get seen as quickly as possible and to get the right treatment and the right care, as Nigel and other colleagues mentioned before. So neighbourhood health remains central part of our ambitions, but we've also identified further areas that we will need to improve. And so we've identified things like the transformation of outpatients provision, because we know, again, some of that provision isn't as optimal as we would need it to be. There are also long waits for certain provision, but also some of that provision doesn't need to be in an acute setting, it could be in a community setting. So there's lots of conversations about providing that better. Urgent and emergency care, I know councillors were asking if the sort of transformation and reconfiguration of the acute ED and A&E is part of a bigger piece of work, and yes, it is part of a bigger piece of work, and what we have called in the NHS nationally the Major Services Review is an ongoing piece of work. We're looking at all pathways, so mental, physical, children and adults. That includes the urgent, emergency, community care. So how do we avoid admissions that are avoidable in the first place, and how do we support people back into the community when their care in an acute setting has come to an end. So part of that will be ensuring that we've got the right pathways, we've got the right capacity in the right places. So it is ensuring that we have done that review, and also ensure that our pathways perhaps will need to be recommissioned. We have a lot of contracts coming to an end in the next 3 to 5 years, so we're looking to start to think through how we look at longer term, so 5 to 10 year commissioning, which, as you know, is part of the 10-year health plan. I think the only other thing to mention is obviously very proud of in the city or East Brighton health team as part of one of our integrated community team. We have 3 integrated community teams in the city, West, Central and East. West are focusing on frailty and having a frailty hub, as well as a children and young people integrated community team, early adopter. Central is focusing on the university population, the younger population, and mental health, because that's a critical area identified in the data. And East chose to focus on a community health hub, amongst other provisions such as screening uptake being a very important one, and mental health, especially in the working age group, was found to contribute to a high number of admissions to hospital from that particular population group. So that community health hub, as I've mentioned before, has received an NHS Excellence Award for the South East. And we're hoping to look at that model for rollout wider across the city, but also across Sussex and Surrey, alongside the government's national plan around neighbourhood health centres. And there's a timeline, as you know, by 2030 to have X amount of neighbourhood health centres in the country. Last thing of note is obviously, I think Sarah mentioned the lung screening. So really happy that the targeted lung screening has begun to identify people much earlier in treatment and much better outcomes and success, as you know, with earlier diagnosis, earlier screening and earlier diagnosis. And then the ADHD Primary Care Connect pilot in Brighton and Hove, very happy to say that this has ensured that we're assessing people much faster. We've assessed over 300 people and improving access by providing support closer to home. And we're hoping to roll that pilot out wider across Sussex. So happy to take any questions.
Thank you, Tanya. Councillor Parrott.
I just want to ask about the ADHD assessment pathway. It's great, and I'm very aware that it's working, and people are being seen a hell of a lot quicker than they were. To their surprise, people were expecting to wait very, very long times, and they're getting appointments within weeks. And in fact, I've got one client who got an appointment within days because of the cancellation. So that's excellent. What I would say is, what about the follow-up that's coming through from that? So although people are getting appointments and they're getting very detailed reports and assessments, which is, you know, as I say, and I repeat, it really is excellent. But then there's follow-up. What do they do with that? How does that help them manage? I think, I mean, again, it's a bigger question and maybe not for this evening, but it's something I'd like to have more information on in terms of, it's one thing to give people a diagnosis and a massive report. It's then about follow-up. I would say that as a clinician myself, the feedback on the services being provided is excellent, and people feel very contained while they're having the interview and very well held during that process. So, that really is, a big thumbs up from me anyway. But then I think there's a kind of fall off the cliff at the other end of that.
Absolutely agree. Absolutely agree. And this was subject to a lot of discussion over the last 2 weeks, is ensuring the pathway to follow up is as clear as the pathway to access. So further work is being done on that.
Councillor Winder.
Councillor Hill.
Apologies, Councillor Hill.
Yeah, I was surprised to hear about it taking potentially days, because it was a couple of years for me in my experience. So that's really positive, to be honest. I'm wondering if somebody is on a Psychiatry UK ADHD pathway and they wanted to sort of be moved onto this pilot, is there sort of provision for that? When is this pilot becoming more than a pilot?
I know that the pilot is obviously contained at the moment, but it doesn't mean that patients can't transfer onto the pilot. The criteria I'm not sure about, so I can obviously go back and double check on that. The idea is that it runs for 2 years, and then obviously learning from that will be taken across other areas. So I can obviously go back and validate some of that for you.
Jeffrey.
I do get a sense of moving the deck chairs around with all these reorganisations. In my lifetime, there have been 38 Secretary of States for Health, and the average stay time in post is about just over 2 years. The longest serving Secretary of State happens to be Jeremy Hunt, even longer than Nye Bevan, would you believe? And each time it feels like, and I send my sympathies to all those people because there's a 50% head count, and it feels like cost saving for the sake of it. If it is improving services, it does seem like its decision making is being moved further and further away from the places where care and health services are being delivered, and that worries me. And also about the democratic control over ICBs. So there are real concerns. We have a new Prime Minister in about 2 weeks' time, and he's talking about making things more local and giving more powers to locally elected mayors. So I don't think anything's set in stone now, and I'm worried about the institutional loss with people disappearing, whether that institutional memory is down the plug hole and lost forever, and we're in danger of reinventing the wheel in another 5 years' time, and there'll be more disruption. But, you know, if you sit in one place, and I've worked in and around the NHS for a long time now, if you sit still and you wait for the merry-go-rounds, you can see something coming round, and they say, oh, that reminds me of regional health authorities. Oh, it is regional health authorities with a different name. So good luck, and I really send my sympathies to those people having to apply for their jobs again. It's we've seen it a lot. Andrew Lansley was a classic example, and we've had a long time picking up his mess. Anyway, it's not a question, it's a comment, but you have my sympathies. But expect some more change in about 2 weeks' time.
Councillor Evans.
Thank you, Chair. Thanks, Tanya, for the update. I just wanted to ask about the neighbourhood thing, and I'm sure that you've had to listen to this particular gripe from me before in other meetings, but as mentioned in a slightly different context earlier by my colleague Jackie, I worry about this east, west and central, because inevitably some of our most deprived areas, including my own in Moulscombe, get lumped into east, along with Woodingdean and lots of other communities that are very deprived. And actually, you might look at an aerial map and go, oh, it's not very far geographically. I think at one point at the top of the racecourse, there is a border that between Woodingdean Ward, East Brighton, Whitehawk and Marina Ward, as it's now called, and Moulscombe and Bevendine. But those areas are not the same, and they are not even easy to get between at all. It's like several buses to get from Moulscombe to Whitehawk. It's not the same place. It's hugely deprived. So is Colding. You know, there's a huge argument for the need for a north hub, because there are some really deprived bits of Hollingdean, Colding and Moulscombe and Bevendine that really have a lot of health issues, and all the conversations we have in other contexts about hard to reach communities and lack of health inequality and the huge difference in life expectancy from places that are only a couple of miles apart from each other, like 9 or 10 years difference in healthy life expectancy. And it just really bothers me that we go, oh, we're doing great in Whitehawk. And it's like, yeah, that's excluding quite a lot of very deprived communities. Thank you.
Thank you, and very, your point is very well made. So I think the East Brighton Health Hub was chosen by the East Brighton to focus on Whitehall, but there are satellite hubs. There are other outreach sites, what they call it, and they're sort of satellite hubs. There are community groups, and included in Moulscombe, which is a satellite hub. There's the Older Boat, for example, in another area that has an outreach satellite hub. So I think what they have tried to do is to focus each of those satellite hubs based on what persons have asked for, so people from the community have identified. So whether it's around prevention, early intervention, cancer screening, blood pressure checks, digital and NHS app support. How do I use this app? You know, what is it for, etc. Health literacy and screening awareness. There are some targeted offers like Pain Cafe, for example, which is some of those satellite hubs. I'm not particularly have the details on where all those satellite hubs are, but I can obviously go back and check that. There's also then the Community Respiratory Clinic, which we mentioned is run and held in sort of partnership with the Acute Trust. And that's again offered in a satellite hub, not at the East Brighton Whitehawk hub. So there are activities happening across the city. It's just not the main East Brighton Whitehawk hub, but there are satellite hubs. But I agree with you in terms of the offer and the approach. We need to look at each of our areas of greatest deprivation and have an offer that meets the need, and that is the plan.
Thank you for that. Just to point out, the old boat is in Hollingbury, I believe, but I still think there is a need in North Brighton to have a main hub rather than satellite hubs. Thank you.
Councillor Simon.
Thank you. I won't repeat that. It was on my list. Just to be clear then, on the last paragraph of point 3 in your report, you say that our teams prepared an initial baseline of proposed locations across Surrey and Sussex. It had as a starting point for engagement and discussion, submitted this list with 70 schemes included. These schemes reflect local insight and need and take account of the most suitable estate approaches in different areas. So I'm interested in knowing, and I appreciate you might not be able to tell us this now, but it'd be really helpful to know where those proposals were, and from whom these ideas come. So who are you asking? Is it the local GP services that are saying, "Oh, we'd like to run a pain clinic," or "We'd like to run a screening for this," or who is coming up with the ideas for these schemes to be included? So that's the first sort of question: where and who. And then the second part of that says, following feedback from national teams, we were asked to streamline this further in terms of prioritisation and make communication, etc. So that suggests to me that you're being asked to streamline in terms of prioritisation because there isn't enough money to fund all 70 of those. So you're being kind of asked to rank them. I'm quite happy for you to disabuse me of that idea or clarify it. So kind of what does that mean? And in terms of timescales, what do we know? We've got any idea about when decisions will be made about which projects are funded and when they might roll out? So there's a kind of where, who, what, and when. Lots of questions.
Thank you. And I think that the simplest answer is neighbourhood health is an evolving piece of work. It's definitely a national evolving landscape. There's now a national framework, as councillors will be aware, but each ICB is approaching it slightly different, which is based on population health needs. So each in Brighton and in the city, we have public health prepared data packs, and that data points to where each community needs varies, and not just as a big patch, but is different in Moulsecoomb compared to Whitehawk. And so we have really robust packs that public health have prepared around disease, access to wider determinants of health, whether it's housing, employment, sort of whether it's screening, tobacco, all the sort of areas that influence somebody's health and outcomes. So that's driving the decision making within the integrated community teams, and the integrated community teams have members from the VCSE sector, from all the NHS organisations. I think the Acute Trust is probably the last to join the party, but happy that the Acute Trust are now involved. So we're talking the NHS in terms of the community, primary care, the urgent bit, but also mental health, because that's really important for us to bring physical and mental health together. Local authority are there, public health, particularly, but adult social care and housing are also involved in the conversations. And latterly, we've had employability leads attend, and we have a pilot on employment work well program also in the east of the city, and the central of the city are rolling out that program as well. And that's based on data saying in terms of high unemployment rates, but also fit notes in terms of persons being off work. So I think each area is particularly looking at the data, but also looking, each area has a community health forum and a patient forum. And they're getting feedback from those patient forum into the community health forum, which then advises the ICT leadership group, which is made up of all those partners we mentioned, as to what to focus on. And some will start off as a pilot to test, to see, is this something we need further investment on? And then obviously the plan is through the Neighbourhood Alliance, who the ICB have now delegated monies to look at how you fund this based on your population need. And there is a process that the Neighbourhood Alliance is adopting across Sussex, not for Surrey as yet, but across Sussex. So each of our 15 integrated community teams across Sussex will have a plan as to what's needed for that population, and they will be putting forward schemes to be funded on a more sustainable basis.
Thank you. And is it possible to know where those proposals are? Obviously, I don't expect you to list them now, but if we could know, what a little bit more detail about what those, what those recommendations are, and sort of like a potted idea of, what data they're based on. I mean, I'm oversimplifying that, and I appreciate that. It's not possible to oversimplify it because it's complex. That would be, it would just be really useful because this is always, like Surrey and Sussex, big area. It'd be really useful to for us to understand what it means for our communities and what may come on stream. And any timescales on that, or is that it's just all evolving and all testing, and so we can't know?
No, and it's not a secret, and no, you can't know. So in terms of the delivery plan, so each ICT will have a delivery plan by the end of March next year, and that will go through the Health and Wellbeing Board. So in the city, these will need to be signed off and owned by the Health and Wellbeing Board, so will be published and will be shared in terms of what activities will be happening within each of those ICTs. They are in very embryonic stage now in terms of those delivery plans, but I would anticipate by the autumn they should be much more robust. I know they've published their first draft internally, so I think those can be shared. So I'm happy to share them with yourselves, Giles, and you can share them with councillors. They're drafted.
Councillor Galvin.
Thank you, Chair. I think this comes down to a change in care of the community. Part of my involvement in the Aging Well process, and as Vice Chair of the Older People, I haven't pushed this, right, have I? Is my speaker working?
Yeah.
And my involvement as Vice Chair of the Older People's Council, rumours have come to my attention of the closing or movement of the eye hospital at the Sussex County. Now, this is an eye hospital that is very much involved in the Brighton and Hove community and services at least over 100 people a week, hundreds of people per week. I'm involved myself. I've got an advanced AMD, and I can understand. I really appreciate the treatment I get. That helps me, the advice that I have, to continue in public service. I did a survey. There was 60 people at a clinic about 2 weeks ago, and I did a straw poll with them and their carers, and they were shock and horror that this may be moved from Brighton or closed down completely. This service is very essential locally, and and the reason I'm bringing it to the attention now to find out if these rumours are valid, and also to prevent an expensive consultation. And I think that there should be inclusive discussions about the way forward in this. Could you confirm any of this, please?
Shall I take that? It is true that we're undertaking a strategic clinical review of the ophthalmology service. That's the whole service, it's not just about the building within the trust. Our Chief Medical Officer, Professor Katie Irch, did write to HOSC as one of the key stakeholders in April, I want to say, and obviously outlined in the letter, and the letter, there's no reason why the letter can't be shared directly with you, Councillor, and explained that we are waiting for some external reports on the building of the High Hospital. It's clearly the High Hospital is in not, again, another example of a building that's not fit for purpose for modern healthcare delivery. But we are waiting for those external reviews. But it does mean that there are some short-term actions that are necessary to facilitate some urgent estate works to make the building at least as safe as we can. And that includes transferring some activity to other parts of the Trust, including Southlands, so that the single lift within the building, within the Sussex Eye Hospital building, can be refurbished, and that work is underway. But it's clear that the roof is in a very poor state. We've got water egress. Goodness only knows what the electrics are like. The theatre is no longer fit for purpose for modern surgery. So there are some significant estate issues with the building, but we are needing to take some urgent remedial action in the meantime until we can get a good understanding of the future options.
May I ask, taking it out of Brighton completely is very, very inconvenient. There are hundreds of people that are treated there every week. And there's also an A&E aspect to this. It's combined with they combine with the A&E at the Sussex County, where anybody is brought in as an emergency or people come in for treatment or hospitalised and have eye problems. They can immediately refer to the eye hospital and have a consultant or operative deal with the situation. This opportunity would be lost if it's moved out of Brighton, and I think the development at the General Hospital, the health hub that's proposed there, would it be possible to have a building there to deal with the AMD situation, included in the proposed health hub being built at the General Hospital? I think it's very, it inconveniences an awful lot of people if this is moved from Brighton in any way.
So Councillor, I'm not suggesting that we are moving all the ophthalmology services off the Brighton Hospital side. What I'm suggesting is that there are some, certainly in the short term, we are having to use some of our other sites as well as Brighton to accommodate the ophthalmology service. But the Eye Hospital is a building, it's 91 years old, is dangerous. It is not fit for purpose. And I would expect HOSC members to be quite irate with me if I allowed patients and staff to continue to work in a building that is clearly unsafe. So we have to take some immediate actions.
But you are still doing the lift at the moment, which is provide increased facility at that hospital. You're paying a lot of money to do this lift, so why do that and then close it down?
So again, we're doing the lift as a short-term remedial action while we work through what the longer-term solutions are around the whole ophthalmology service. It's not just about the eye hospital, but the whole ophthalmology service. So in the meantime, we are doing some repair works to the one and only lift that is in the building. You'll also appreciate there are fire regulations that have changed considerably over the years, and so there are several factors to be taken into account around some of the fire regulations, and the lift repair is part of that as well.
If, as you say, this thing is out of date, or the hospital can be not used, or fire regulations can be met, what do you intend doing with the building? Just...
Councillor, that is all work that was undergoing at the moment. We have made no decision yet around what the future building is, but what I can say is that I have to make sure that if we are seeing patients in any building, that it's safe to do so. And at the moment, that building is not safe.
But you're still seeing hundreds of patients a week at the moment. I mean, at the clinic I was at, there were 60 people waiting for injections, including myself, and they said I did a straw poll. And these people feel deserted if it's moved out of Brighton. These are people of Brighton and Hove. and care in the community. There must be some other provision available within the city where this can be moved to.
We could have a conversation about this all night if you like. I am not going to change my position that the building is unsafe, and I cannot allow patients to be seen in that building while it remains unsafe. There are patients that have been seen within the main hospital site. There are other patients who have been seen in other parts of the trust, including Southlands, and that's obviously in discussion with those patients as well, and that's mostly outpatients.
Councillor Galvin, I'm going to put a hold to the questions at the minute because we're repeating ourselves. More than happy to take these questions outside of committee and share them with the appropriate body. But for the moment, I'm going to concentrate back on the agenda item, which is cancer diagnosis. Sorry, the NHS Change ICB update. I'm going to ask Councillor Winder to ask her question. Thank you.
Thank you, Chair. Thank you.
I just wanted to come back to the process for mapping out where these health hubs and centres might be. And is that something that you're in the process of doing currently? And might this come back to this meeting again when you've got a better idea about how they will be distributed? Because I think people, certainly in my ward, which is Hanover and Elm Grove, people would find it almost impossible to travel all the way over to the East Brighton one. There are a lot of very elderly people in that ward, and the GP surgery has been moved out there, and so nobody has anything very convenient to be able to get health advice. So I imagine that if you were to look in detail at, you know, some of the circumstances of the different areas of the city, you might find an in-depth need for some of these in as many areas as can be found, really. So is that your aim and objective?
Thank you, Councillor, and absolutely. So it's an early scoping phase currently, and I think there are several factors. So to meet the requirement for a neighbourhood health centre, there are about, I believe there are 25 areas that you have to check, and some of those including, does it have site for diagnostics? Because if diagnostics can't be cited, then it's not a centre, it could be a hub. So there are some areas that will be on the trajectory to being a centre because the estate exists, we can modify it. So for example, Hove Polyclinic, we do have a lot of facilities there already, but we need additional facilities in order for it to meet the criteria to be in a neighbourhood health centre. There might be the need for a health hub, for example, in your patch or in other wards, and that's a slightly different tact, and it's best delivered out of community assets rather than a purpose-built health facility. So there are two things. There's a neighbourhood health centres, which is a big national government direction, and then there is communities agreeing what they need is a health hub, which is a drop-in, more informal setting to deliver services such as care, social care, and health. In terms of the delivery plans that previously mentioned, those will come to the Health and Wellbeing Board and then obviously discuss with members of the public to see if it meets the needs. And it might be a health hub works in one place but may not be suitable for another place. It could be something else.
Could I just ask one more question? The sort of borderline of that ward is also in a very, very deprived area, and those people have no access to any resource or amenity at all, not even a shop. So I think I'm just assuming that you'll be mapping all this out about what people do have access to, the travel arrangements for getting to a different health hub, or the kind of other amenity that they might have, and that would come into the mapping process. I mean, are you able to confirm how that would work?
Briefly, in terms of the process, yes. So there will be mapping. So mapping will involve access to, well, is there a need for a hub, or is it more individual care that's required in a multidisciplinary joined up way? And that includes working together for mental health, physical health, which doesn't happen very well currently. And that's the whole neighbourhood approach, is integrating care and utilising teams working together to get the best outcome for people, instead of isolated patches of care or social care, which we know does not optimise that person's journey or their outcomes. So that's the first point. Having a health hub could meet the need in certain communities, and it could be building on what's already there. So, for example, the National Health Centres is looking at local authority estate as well as NHS estate. And obviously, local authorities have all been written to look at what potential mapping they can do with the NHS. So all the mapping will include local authority as well as the NHS. And from my understanding, there's been some models done in other places in the UK, not clearly where those are yet, but we'll be early adopters of this neighbourhood health and neighbourhood health centres. So we're looking to those to, again, see how they mapped it, what they scoped, and how they agreed that was needed in this area as opposed to not being needed in another area. So it's early stages, but I can assure you that mapping and intense mapping will be done to agree where and how neighbourhood health is delivered.
Thank you very much.
Do I have any further indications as questions? I'm not seeing any, so thank you, Tanya, and thank you, Nigel, for taking questions this evening. I'm now going to put the report to members. Are you happy to note the report? Thank you, and I now call the meeting to a close. Thank you very much for your endurance.